Hello everybody and welcome to the cardiovascular section. Now the physical finding flashcards are a unique endeavor. They are the endeavor to have you learn all the heart sounds, breath sounds, bowel sounds, skin findings that you will see on step 1 of USMLE. And to make sure that you can remember it, we're going to show you roughly 5 times more images that are in the physical finding flashcards that you can get from a bookstore or from Amazon or any form of bookseller. We're going to make sure that this experience adds on all of the pathology of the skin findings. So you'll be shown all the microscopics. It's going to show you the physiology of the cardiovascular section. It will show you the microbiology of the infectious disease findings, and we'll make sure that the video endeavor, this tool right now, adds on everything for step 1. The box will have everything on step 2 and 3 on it, but step 1 is harder because just like this video, it adds on the histology and all of the basic science that you need to do well on your test. In addition, it is exciting. Cardiovascular, let's jump right in. The Allen test. We don't like tests that are named after people because we have to retranslate that. Is there an Allen test? There's John test, Thomas test, Sarah test. An Allen test, when is this test done? How is it done? And the other part is simply, when is it indicated? Well, the Allen test is a test that is done to make sure that the circulation in the hand of a person is adequate. It's a hand circulation test. Now, as recently as this week, I saw a patient that had insufficient circulation of the radial artery. And when they put a vascular device into one of the other arteries, it actually necrosed the hand because the patient needed an Allen test to test the circulation of both sides of the hand. So what you do is you occlude both arteries, both the ulnar and the radial artery, and what you make sure is that the hand becomes raised, so you empty it of blood and let it turn pale. Then when you release one side, you're releasing only one side of it, what happens is that you'll be able to see, does the ulnar artery have enough capacity to perfuse the whole hand? So this is a test of saying, is the ulnar artery sufficient to be able to perfuse that hand? And you look to see for the flush that develops. Now, an Allen test is done basically to see, can I put an arterial line in? The basic science answer is to say, what is the mechanism? It looks to see ulnar artery perfusion. And it assesses whether there's an ulnar artery that's sufficient to perfuse the whole hand. If the ulnar artery is sufficient, then what will happen is that the hand will turn red when you release the ulnar side, showing perfusion, and it avoids the damage of necrosis. What we see here is a picture of the Allen test. On the left-hand side of the picture, we're occluding both the radial, and the ulnar. Radial and the ulnar, occluding both of them. And then what we're doing is we're going to release one side and see, does the hand stay perfused by just releasing the ulnar artery. That's how you test vascular flow. It also is an anatomy question, isn't it? It shows you this arc of vessels between the radial and the ulnar artery. That's an artery flowing into another artery. Kind of interesting, isn't it? Yes, it is. And this is a picture of the occlusion of the ulnar artery, showing decreased perfusion of the hand. There shows that the predominant distribution of the radial artery is one half of the hand with the thumb on it. Here we go. You're occluding both sides. Occluding both sides. We're juicing out, milking out the hand of all the blood so that it will turn pale. It is the pallor that allows us to see whether the perfusion is happening. Now you're going to see a release of one side after the pallor and see whether or not, whoosh! Wow, look at that red hand. Isn't that amazing? It's like post-masturbation here. Okay, and we have the red hand here showing you that that hand can be fully perfused by the ulnar artery, and this means that the radial artery is fully intact. That's the Allen test. Now, next one, the ankle brachial index. You might say, why are we starting with Allen test and ankle brachial index? And that is the bright answer called publishing, putting these in alphabetical order. Very good. Alphabetical. How interesting. Ankle brachial index. First of all, what is it? Ankle brachial index. I think it has to do with the ankles and the brachials. Yes, it's a blood pressure test. What disease does it look for? Ooh, it looks at the difference in the blood pressure between the ankles and the arms, and the ankles and the arms. The most accurate test of any vascular structure is always an angiogram, an arteriogram. The ankle brachial index measures the blood pressure difference between the arms and the ankles. What should normally be greater? The blood pressure in the arms or the blood pressure in the ankles? And the answer is the ankles, particularly when standing. When I'm standing up like I am now, my blood pressure for me, because I'm a fairly tall guy, is about 60 to 80 millimeters more than it is in my arms because of gravity. When you're lying flat, they should be about equal. And standing up, ankles should be greater. But at no point ever in a normal person should the blood pressure be greater in your arms. This is a very common misunderstanding because the average student says, wait a second, isn't this close to my heart? Isn't the blood pressure going to be greater there? Very natural, logical, wrong answer. Even though it's physically close to your arm, it is in fact based on gravity. That's right. That's why toilets flush down, they don't flush up. Gravity. So they should be within 10% of each other because 10% is sort of the standard of the measurement difference. Now, remember that these cards are meant to be able to have you do well on clinical rotations when you become a third-year student, because remember, the day after you finish Step 1 or Comlex 1, the day after you finish that, you're going to become a third-year student, and you're going to be on rounds, and your attending is going to ask you these. But the Step 1 question also says, what's the mechanism? What I just said, gravity. So the ankle blood pressure should be at least equal when you're lying flat. So therefore, ankle brachial index is a very important answer to the question, what is the best initial test of peripheral arterial disease? And the word peripheral arterial disease is a better answer than peripheral vascular disease, because peripheral vascular disease could imply the veins. But peripheral arterial disease is where the insufficiency really is. So a severe abnormality is a lower ratio. In other words, when the ankles are really much lower, implies greater obstruction. The most accurate test of any vascular structure is always the angiogram. What does it look like? It looks simply like, and here's one great thing, is that if you're a fast student, pause and read. If you're a slow student, you can go over 57 times, as much as you want. You're looking at the blood pressure between the arms and the ankles to see which one is greater, to see if there's an obstruction. That obstruction makes the blood pressure in the ankles much lower, decreasing the flow. Remember, aspirin and cilostazol, statins. And what's the best blood pressure medication for peripheral arterial disease? The best blood pressure medication in peripheral arterial disease is an ACE inhibitor. Bonus question, bonus point is, do calcium channel blockers help in that? Do calcium channel blockers help in that? And the answer is no, they do not. Calcium channel blockers do not help because this is not a vasospastic problem. You'll look at the difference between the blood pressure between the arms and in the legs. Our next question. Let's listen. So in this person, if we tell you this is heard over the heart, it depends on which area of the heart. If it's heard at the lower left sternal border, it is diastolic decrescendo. And a diastolic, and that diastolic decrescendo murmur is aortic regurgitation or aortic insufficiency. There is no fundamental difference between aortic insufficiency and aortic regurgitation. They both mean about the same thing. Aortic stenosis would be if the question said that this was a systolic sound. Because I'm telling you that it's a diastolic sound, that's what makes it aortic regurgitation. Now, this is best heard over the lower left sternal border. The most common cause of aortic regurgitation, is insufficiency of the aortic valve. It is a floppy, loose valve with a dilated aortic root. It is things like hypertension, stretch the heart. Marfan, stretch the heart. Syphilis, stretch the heart. Now, anything that stretches the heart, like hypertension, that's by far the most common. Dilated cardiomyopathy will do it and dilates the aortic disease. Hand grip. Ooh, what's the hemodynamic effect of hand grip? Squeeze, squeeze, squeeze. Squeeze, squeeze, squeeze. The hemodynamic effect of hand grip on the heart is to increase afterload. Okay? To increase afterload. Valsalva prevents venous return to the heart, and squatting and amyl nitrate. Squatting increases venous return to the heart. Amyl nitrate is a vasodilator. Amyl nitrate is the opposite of hand grip. Amyl nitrate decreases afterload. Now, the other findings on the exam, aortic regurgitation is loaded with all sorts of extra findings on exam. Now, at the beginning, if you got this on the third time, you should feel terrific, because to understand the auscultatory maneuvers is hard at the beginning, but it's going to be made easier. Aortic regurgitation is a diastolic decrescendo murmur, and it is heard at the lower left sternal border, and that means, and also it should radiate down. Okay, should go radiating down, because what it does is it follows the aorta like a horn, follows that aorta, and it's most often secondary to things that dilate the aortic root, like hypertension, Marfan's, Ehlers-Danlos syndrome. Ooh, remember Ehlers-Danlos syndrome? I feel so stretchy. I'm stretchy. It's like living in a yoga. It's like living in Bikram Yoga Center, like living there in stretchiness. And Marfan's dilates things. And Reiter's syndrome is a reactive arthritis with HLA-B27. This is the HLA-B27 things. Endocarditis does it because endocarditis causes vascular insufficiency and dilates the aortic root. All of these things are different ways of saying, do you know what dilates the aortic root? Hand grip increases afterload. Hand grip pushes blood backwards. Hand grip contracts the arteries of the arm, smushes the arteries of the arm. Hand grip squishes the arteries of the arm and compresses those arteries so that it makes it harder for blood to get out of the heart. So hand grip is the opposite of an ACE inhibitor. If you treat regurgitation with ACE inhibitor, hand grip makes it worse. If you treat it with ACE, vasodilator, hand grip makes it worse, because hand grip squeezes those arteries. If it gets better with an ACE inhibitor, it'll get better, improve, softer with amyl nitrate, because amyl nitrate dilates the vasculature. Amyl nitrate dilates the vasculature and makes it easier for blood to get out of the heart. Valsalva, we get that? Amyl nitrate is a vasodilator, an arterial and venous vasodilator. So it decreases afterload. That's the major thing. Its effect is the opposite of hand grip. Hand grip squeezes the arteries. Amyl nitrate relájate, suave, raslapsia to arteries. And Valsalva decreases venous return. Now, knowing the mechanisms of these auscultatory maneuvers is considered indispensable for all three steps of USMLE and complex. It's considered indispensable for all three steps of USMLE and complex, because even though we almost never do it clinically, it means you understand the murmurs. And that's what step 1 is about. Do you understand the mechanism of the murmurs? Even if you don't actually do it, do you know how to do it? Squatting does the opposite of Valsalva. Squatting increases venous return by squeezing the leg veins. Squatting squeezes the leg veins. Squatting squeezes the leg veins. And what squatting does is increase venous return to the heart because it squeezes your thighs. Don't your thighs have a lot of volume? If we squeeze them, your heart is filled. So aortic regurgitation or insufficiency also gives a high bounding pulse because the heart knows that it's insufficient and a lot of the blood in those blood vessels is going to regurgitate backwards. So what happens is that the blood shoots up only to splash half back. It shoots up only to splash half back. And that's why aortic regurgitation gives a huge high pulse, sometimes also called a water hammer or Corrigan's pulse, and then it rapidly diminishes. Demusset's sign, man, can you imagine like that? What it must be like to be Demusset? What did you do? I got my name on a side that's head bobbing. Yeah, well, Demusset actually was a French playwright and a poet from the some 19th century French playwright and poet who had aortic regurgitation. It's actually not a doctor. It's named after a guy who actually had it. And it's the head bobbing that goes with the high bounding to pulse. Hi, how are you? What do you have? I got aortic regurgitation. Oh yeah. Demusset. Got the aortic regurgitation. Gonna down. And that's Demusset's sign. And also has a lot of other odd things that don't happen in any other disease. Pistol shot pulses are heard over the femoral arteries. And de Rossi has a sign. I know. Isn't it terrible? You have to memorize all these things. But you know, we really want you to know this about bruits and thrills and bruits. And these are basically diastolic murmurs. Basically, this is a sign of extremely high rapid flow that can be heard in your femoral arteries. Now, a Quincke pulse, which we're going to show you later on, you're going to see a Quincke pulse. A Quincke pulse is a sign of pulsations in the nail beds. A sign of pulsations in the nail beds from vascular flow. That's a Quincke pulse. Vascular pulsations. Now this is showing you one of my favorite basic science step 1 laws. And one of Dr. Fisher's favorite basic science step 1 laws is the law of Laplace, the law of the place. And the law of Laplace says that as things widen, the wider things are, the greater the tension in the walls. The wall tension, the wider the something is, the greater the radius across, the wider the radius, the wider it is, the more the wall tension. And this wall tension is a tension that's trying to pull apart the wall, trying to stretch the wall, yank the wall, widen the wall, pull it apart. And the wider it is, the more wall tension there is, pulling apart that blood vessels. So wider things, as the radius goes up, in order to maintain that pressure the same, the wall tension rises. In order to keep the pressure the same, the wall tension rises. And that's why, as the radius goes up, simple question, as the radius goes up, another way of saying it is wall tension, and that means wider things widen even faster. That when balloons blow up, they blow up even faster at the end. Small balloons are hard to inflate. Big balloons are easy to inflate because wide dilates and narrow collapses. That's why when people get dilated aortas and when they get dilated hearts, they tend to dilate faster and faster and faster and faster, and then you die. Everybody who has dilation automatically has regurgitation. Everybody who has dilation automatically has regurgitation Because as the heart stretches up in size, what happens to the size of those leaflets? What happens to the size of the leaflets as the heart stretches up in size? As the heart stretches up in size, do the leaflets increase in size? The answer is no. As the heart dilates up, the leaflets stay the same. So therefore, as the heart dilates up in size, as if the leaflets stay the same size. If the leaflets stay the same size, it means there has to be regurgitation. Because dilation with leaflets staying the same size means regurgitation because they separate. When your ass gets big, does your underwear change in size? And the answer is no. As your ass gets big, the underwear has to separate off. It doesn't cover as much. And that's why the leaflets. Wider things get bigger faster. Wider things dilate. Smaller things collapse. Wide blood vessels continue to get aneurysmal. Smaller blood vessels don't get aneurysmal. If this is the airway, because what we're representing here is airways, the same thing of the law of Laplace is true. Small collapses, large dilates. Small is easier to collapse, but as you regurgitate and you get wider, this will happen and get wider and wider and wider. This is why in aortic stenosis, by the time you get congestive heart failure in aortic stenosis, by the time you get congestive failure, you're going to be dead in 1 year to 18 months. Dead in 18 months. Worse than metastatic cancer is a dilated cardiomyopathy. Dilated cardiomyopathy dilates faster. When you get dilated even more, you explode. Now, one of these is small and one of these is large. Which one of these will expand? Let's go back to our law of Laplace. We said small collapses, large expands. And this is the law of Laplace again. Small collapses, wide expands. So if we're looking at these balloons, which of these has greater wall tension? Small yellow or big blue? Oh, what we see here is that the wider balloon dilated, the smaller one collapsed. Because isn't it interesting? Even though there was more air in there, it was under less pressure. And it caused the wall tension in this one is less than this wall tension. That wall tension is greater, and therefore it squeezed the air into the bigger one. Wow, I keep watching that day in and day out. What do we hear? Oh, a diamond-shaped systolic murmur, crescendo, decrescendo. Crescendo, decrescendo, diamond-shaped systolic murmur, and that is aortic stenosis. The second right intercostal space, aortic stenosis. Crescendo, decrescendo, aortic stenosis. Now there is one other thing that has this diamond shape, and that's hypertrophic obstructive cardiomyopathy, HOCM. Now HOCM is an absolute must-know subject for step 1. We love HOCM. We love those basketball players going dribble, 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 shoot, score, die. Sudden death. Yes, it does cause sudden death in healthy young athletes. That's true. But most people with hypertrophic obstructive cardiomyopathy, what's the most common presentation? That is a great question. HOCM. Most common presentation of HOCM is not sudden death. It's not syncope. It's good old-fashioned shortness of breath. So HOCM presents with shortness of breath. So one of the ways that you can tell apart aortic stenosis from HOCM is HOCM presents with a sudden death, but not as much as it does with shortness of breath. Okay, now the most common symptom of aortic stenosis? HOCM is shortness of breath. The most common symptom of aortic stenosis, it's actually angina, chest pain. That's the most common. And it radiates, aortic stenosis radiates to the carotids. It radiates up to the carotids. And now, ooh, look at this. We're already repeating. We've only been together for a few minutes. We haven't even been together for 20 minutes. And already we're repeating. Isn't that fantastic? It's like a boring relationship. I've known you for 20 minutes and you've used that same joke 3 times. You're boring. So aortic stenosis, hand grip, the effect of hand grip, squeeze the arteries of the arm, increases afterload. Now, Valsalva decreases venous return to the heart, because when you decrease venous return to the heart. Squatting does the opposite of Valsalva. Valsalva and squatting are the opposite of each other. If Valsalva decreases venous return, decreases Valsalva venous return by increasing intrathoracic pressure. Squatting increases venous return. Squatting increases venous return. Now, the therapy for aortic stenosis, there's no medical therapy. No medicines, not for aortic stenosis. Now this is aortic stenosis, crescendo, decrescendo. It's heard at the second right intercostal space, and it goes up into the carotids. The most common presentation is angina, chest pain, and the worst, the one that means you're going to die the soonest, is congestive failure. Now why is angina the most common presentation? Is because 2/3 of people with aortic stenosis have coronary disease. 2/3 of people with aortic stenosis have coronary disease, so they have a greater problem already. Their coronaries are diseased, and therefore they can't deliver blood. Number 2, does the person with aortic stenosis have an atrophic ventricle or hypertrophic? Atrophic or hypertrophic? Aortic stenosis is associated with a hypertrophic cardiomyopathy. Aortic stenosis makes the left ventricle big and thicker because it's going, yeah, I get to go big and multiple, macho, and it gets bigger, so you have an increased demand. So aortic stenosis has a decreased supply with an increased demand. Aortic stenosis has a decreased supply because the coronaries are narrow with an increased demand. The other thing is, the aortic valve is right in front of the coronary ostia. Anatomy question. Where do the coronary arteries start? Coronary ostia. Coronary ostia and the coronary ostia are just distal to the aortic valve. So you're blocking flow into my valve, man. The worst is congestive failure because you've dilated the heart. Once the heart dilates up in size, what can you do to restore it to normal size and shape? Once the heart dilates up in size, what can you do to restore it to normal size and shape? Nothing. Once the heart dilates up in size and you get a dilated cardiomyopathy, all you can do is transplant it. Do you know that we don't have a therapeutic way to shrink hearts? So you die instead. Now, the basic thing is that aortic stenosis radiates to the carotid, mitral regurg radiates to the axilla. Aortics to the carotid, mitral valve go to the axilla. Hand grip increases afterload. Because hand grip increases afterload, does it make it easier for blood to leave the heart or harder for blood to leave the heart if you increase afterload? If you increased afterload, it makes it harder for blood to leave the heart, and therefore hand grip softens the murmur because it makes it harder for blood to leave the heart. Aortic stenosis is decreased because it makes it harder for blood because the pressure goes up in the arteries. The pressure goes up in the aorta. Now, Valsalva decreases the murmur because anything that decreases venous return decreases left-sided murmurs for almost all of them. Valsalva decreases aortic regurg, decreases mitral regurg, decreases aortic stenosis, decreases mitral stenosis. Valsalva, less blood in the heart. Less blood in the heart, less murmur. Less blood in the heart, less murmur, softer murmur. Like the difference between this and this. More blood, more murmur, less blood, less murmur. For everything, in fact, except mitral valve prolapse and HOCM. Mitral valve prolapse and HOCM do the opposite of all of those. Now, these cards are useful as one item just to be able to get all the murmurs. Valsalva decreases venous return, and standing suddenly decreases venous return. Valsalva means less blood in the heart, and standing means less blood in the heart. And basically what this means, it decreases preload. Squatting increases preload. Leg raise increases preload. Squatting increases venous return. Leg raise, lifting your legs in the air, increases venous return. So squatting and leg raise, more blood, more murmur. More blood and more murmur, and they increase. More blood, more murmur for everything except mitral valve prolapse and HOCM, which go the opposite. Aortic stenosis, there is no medical therapy. You basically have to replace the valve. You have to replace aortics and remove balloon mitrals. Replace aortics and balloon the mitral valves when they're stenotic. You can't balloon in an aortic. Why not? I want to balloon in the aortic. You never let me balloon in the aortic. Daddy, Daddy, I want an Oompa Loompa. I want to balloon the aortic. And you can't balloon the aortics because of the pathology. The pathology of aortic stenosis is that in aortic stenosis, you have it from calcification. Bony, rocky hard. And you can't balloon bony, calcified, rocky hard things. You can only balloon fibrosis. We balloon the valves, that is mitral stenosis, because mitral stenosis is fibrotic, because mitral stenosis is from rheumatic fever. So you can balloon the mitral and replace the aorta in stenotic lesions. Now here is a sign of the stenotic valve. This is the normal pressure in the left atrium. Not much, 5 or 10, very small. If you're standing up, it's actually subatmospheric. Lying flat, it's about 5 or 10, very small. And basically the systolic blood pressure is 120. You notice that the systolic pressure in the aorta is 120 with the systolic pressure in the aorta in the ventricle. You notice how that's the same number, 120, 120? Well, there's a reason for that. The systolic pressure in the ventricle and the aorta should be the same, because the systolic pressure in the aorta is the same because there should be no barrier. Because there should be no barrier to the flow of blood up into the aorta. There should be no barrier to the flow of blood up into the aorta, because it should be fully open. Now this stenotic valve, do you see the red thing? That's the aortic stenosis. That stenotic valve there, you see how the pressure here is 200? See 200? Really high? 200? Squeeze me! But the pressure there is only 110. How come the pressure there is so much lower? How come it's so much lower? The answer is that there's a gradient because all the backflow. The stenotic valve makes this pressure higher, and also the left ventricle is thicker. The left ventricle is thicker. So that's a valve gradient. So that is a valve gradient, because when you have a blood pressure that's much greater here than there, because this is the valve gradient, and this is the single greatest measure. What's the difference in blood pressure between the left ventricle and the aorta? That valve gradient means difference. Valve gradient means difference. So when you have that valve gradient being really different, it means you got a sicker heart. The greater the gradient, the worse the heart. The greater the gradient, the sicker you are. The greater the gradient, the worse the heart. Replace you're gonna die. I'm gonna die. I'm gonna die. Oh, my gradient's really high now. My gradient's really high now. My gradient really high now because I'm gonna die. I know, like your mother has aortic stenosis and I just made fun of it. Well, it's better to laugh than to cry. You know what I mean? Why do angels fly? Because they take themselves lightly. Now, this is a graphical representation. Okay, this is a graphical representation of aortic stenosis. This is a graphical representation of aortic stenosis because this shows you the gradient. This is the aortic pressure, the green line, aortic pressure. Why is the aortic pressure so much lower than the left ventricular pressure? Left ventricular pressure, aortic pressure. Why is the gradient, okay, why is the difference there? Because there's a stenotic valve in the way. So this, look, 200, 110. So, 200, 110. So this is a representation of that valve gradient. The aortic pressure is so much lower than that left ventricular pressure because there's a stenotic valve in the way. And the more that difference, the greater the gradient, the greater you need to be able to have that valve taken out. Now, if less blood is going through a stenotic valve, how come, as you have a worsening aortic stenosis, how come there's more noise? This is a very thing. You see, most people say, they go, yeah, sure, stenotic vessel, narrowed vessel, makes noise. Well, is flow greater or is flow lesser in a person who has aortic stenosis? Flow is lesser. Well, if flow is down, how come it's louder? Wouldn't normally things be softer and quieter if there's less flow? Well, here's where physiology comes to the rescue with an explanation. So our next basic science physiologic point, and remember the flashcards, the ones in the box are really set up just for step 2 and 3. The video has the step 2 and 3 end and adds the step 1 end on it too. Because the step 1 end says, do you know what a Reynolds number is? A Reynolds number is a numerical measure of turbulence. It's a numerical measure of sound and turbulence. You see, the narrower the vessel, although the flow is down, the flow that does happen happens faster. The flow is down, but it's faster, and since it's faster, it's more turbulent. Well, how come isn't that net equal? The flow went down, but the speed went up, then it's equal. Actually, because it's not equal. The flow goes down, and the velocity goes up, so that's equal, Conrad? No, because the flow goes up faster. Speed of that flow, the velocity goes up more than the flow goes down. The flow goes down, but the velocity goes upper. And that's why it's faster. You see, what ends up happening in bruits is that the flow goes down, but it happens faster. Bruits of the renal artery, narrowing. And when the diagnosis, when the bruits, what is it? What is it? It's renal artery stenosis. The most accurate test of all vascular lesions is angiogram. And the therapy for narrowed things, in this case is dilation. But how the dilation? How to dilate it? So bruits of the renal artery have a high-pitched sound at the flanks and goes into the abdominal walls, because back in here is where your renal arteries are. The bruits of renal artery mean renal artery stenosis. They mean renal artery stenosis, and they're very specific. The problem is that renal artery stenosis can easily be present without a bruit, so the presence of a bruit is highly specific. The presence of a bruit is highly specific. And that's why it means renal artery stenosis. But renal artery stenosis, you see, the problem is that the bruit is not there half the time. So the most accurate test of all vascular structures is an angiogram, okay, and therefore the therapy is angioplasty, balloon angioplasty. The same way for mitral stenosis, it's valvuloplasty with a balloon. Angioplasty and stenting it. Oh, which one? We got a narrow one, we got a normal one, we got a narrow one, we got a normal one. Yes, we do. And you see what happens is that when you have that plaque building up there, you put a catheter in there and you balloon it. Take a catheter, put it into the renal artery, and pop it open with a balloon. You have a narrowing over there. You see that narrowing? And that narrowing has to be ballooned with a stent. That stent is placed, you get a balloon in there, and you put a stent in there to prevent it from restenosing. Without a stent, these blood vessels tend to restenose, and that's why you do this in coronary arteries with a stent, and you do it in renal arteries, and you coat the stent. You coat the stent with something that prevents restenosis, things that inhibit lymphocytes. So a Reynolds number is a measure of turbulence. Oh my God. Oh, that was frightening. It looked like mathematics, man. Don't scare me with that physics. Measure of turbulence, velocity, density. Oh my goodness. This is scary. Okay, they see diameter. Diameter means diameter of the tube. Velocity, the faster something goes, the faster something goes. The faster it goes, the more the turbulence. And the greater the diameter, the more the turbulence. The greater the diameter, the more the turbulence. Now, the more the viscosity, the less the turbulence. Viscosity goes up, turbulence goes down, because potato rivers flow with less turbulence. Mashed potato rivers flow with less turbulence than water rivers. Chocolate rivers flow with less turbulence than water rivers because there's more viscosity. Now, here's the thing that's said, well, flow goes down, how come turbulence goes up? And that is because the velocity is going up with the power of a square. As the surface area goes down, the velocity goes up with the power of the square. Inverted. The velocity is 1 over the surface area. 1 over the surface area, and surface area is pi r squared. So therefore, as surface area goes down, velocity goes up much more, because velocity goes up to the power of the square, and that's why Reynolds number says the more narrow blood vessel, you're going to have a bruit. The more narrow the aorta, the more you're going to have a murmur. The more narrow the mitral valve, the more you're going to have a murmur. The flow goes down. Next one, Cannon A waves. Cannon A waves are where? A waves in the neck. Cannon A waves are in the neck, and they're described. What are you thinking about when they're described? They're a sign of? They're a sign of the atrium contracting against a closed tricuspid valve. They're the sign of the atrium contracting against a closed tricuspid valve, and blood bounces backwards up. Blood bounces backwards up into the neck veins. Blood bounces backwards up into the neck veins, and the most accurate test is looking at an EKG. Cannon A waves is a giant pulsation in the neck veins, and it's caused when the atrium contracts and the blood goes forward, but instead of the blood going forward into the ventricle, the blood bounces backwards up into the neck veins. The blood bounces backwards, so Cannon A waves is caused by atrial systole against a closed tricuspid valve. It's caused by atrial systole, caused by atrial systole against a closed tricuspid valve, and it makes it go up like a cannon shot up into the neck veins. Cannon A waves. Now, if the case describes bradycardia, this is third-degree V block. This is where the atrium and the ventricle are out of dissociation. They're dissociating. And the atrium's beating like this, and the ventricle's beating like this. And the atrium's beating like this, and the ventricle's beating like this. And it's like, you're beating like this, I'm beating like this, you're beating like this, I'm beating like this. They're dissociated. So the atrium is contracting against a closed tricuspid valve, and the blood is bouncing backwards, up into the neck veins. The most accurate test is an EKG. So the reason that we have these physical findings cards put together like this in one group is because these are things that when you see patients, they're just not present a lot of the time. A lot of them, like head bobbing, Demusset's sign, de Rosier's sign, quinky pulse in the fingernails, these are in fact largely very 19th century descriptions. Truly, they're over 100 years old because cardiothoracic surgery is a pretty well-formed specialty for more than half a century. So most of them would be prior to 1950, because or a place where you can't get operated on. Because these things like head bobbing and Traub's sign, de Rosier's sign, even Canon waves like this, they're signs of when you didn't just do cardiothoracic surgery and pop the valve out. But you're going to have to dissociate in your brain the part of your brain that says, oh, this is just a bunch of BS, I don't need to know this, this is just ridiculous, versus no, you are expected to know it, period. I'm sorry, you just have to know. Canon waves are atrial systole against the closed tricuspid valve. You do an EKG, that's the, okay, and here we are looking at them. Ready? Wow, disgusting, isn't it? Oh my God, that's so creepy. Up into the neck veins. Ooh, ah! Imagine what it's like to be him. And they're like, why don't you put a pacemaker in the person and stop the third degree block? Well, why don't you give atropine and speed up the heart rate? Oh, but then who would the medical students have to examine? Next one. Let's see. This is, what do you see? What's the difference? What's the difference between saying a noise and a bruit? What's the difference between the noise and the bruit? Well, everything is sexier in French. It's the bruit and the carotid artery. And when the bruit is in the stem, you're thinking of carotid artery stenosis, the most accurate test. See how we're repeating? It's a vascular structure, so angiogram is the most accurate test. A bruit is heard with the bell over the carotids, and you should not hear anything. There should be no sound. In other words, there should be no sound of the left ventricular ejection. There should be no sound of the renal arteries filling. There should be no sound in the carotids. So any sound in the carotids is abnormal. How come you can have a murmur or a bruit there if the flow is down? And the answer is because it speeds up. The most accurate test is either a duplex ultrasonogram and sometimes an actual angiogram. Now, we don't have to actually do an angiogram with a catheter too much anymore for anybody. That's sort of passé. In other words, putting a catheter in you and injecting contrast that kills your kidneys is not needed, because duplex ultrasonogram is the sonar that was used to look for Nazi submarines in the Second World War. And now we adapt that. In the heart, we call it echocardiogram, and in these vascular structures, we call it duplex ultrasound. And you don't need the angiogram to see the narrowings. Remember, flow down, but speed up to the power of the square. Oh, look at these big legs. Ooh, why is that leg much bigger? Well, one leg is bigger. What is the diagnosis? The test and the therapy. Now, this is a Conrad Fisherism. You see, when we look at these questions like this is the way I want you to study. I want you to study by saying, you don't know which question you're going to get. You don't know where you're going to get asked, what's the diagnosis? Well, this is a DVT. What is the test? Well, duplex sonogram. Oh, what is the therapy? And the answer is heparin, warfarin, heparin, dabigatran, rivaroxaban. You see, when you study this way, you don't know what question you're going to be asked. So we're going to go through all these, and we're going to speed up the velocity because we can. And we're going to speed up the velocity to say, time to say, give us all the questions. Why ask for one miracle? Ask for all of them. Here's a deep venous thrombosis. The duplex ultrasonogram is the most accurate test, and what you say, it's usually the only one necessary. Venography is nearly never necessary to put a catheter in there and do a venogram. Almost never necessary, and we treat it by using heparin. You can use low molecular weight heparin. IV heparin has the same efficacy, so there's no reason to use IV heparin, or you can just use oral rivaroxaban without any heparin, and just bang, that's just as good, and you don't need to monitor the INR like you do for warfarin. You just give the rivaroxaban without the INR. Next card. Now, the displaced point to maximum impulse. There's a cardiac finding. The point to maximum impulse should be down there just past the nipple. And when it's displaced and pushed over to the side, it means it's pushed over to the side. And what does it mean when it's pushed over to the side? It's an anatomy question. Now let's look at some anatomy, because the displaced point to maximum impulse means my left ventricle is displaced laterally. Laterally, something you feel, point to maximum impulse. You feel it as the heart hits the chest. You feel it. It's a palpatory sign. It's a palpatory sign of cardiomegaly. And what we do is we use it to say that you have left ventricular hypertrophy, and we use it to test your knowledge of anatomy. Displaced point to maximum impulse, I feel it in a different spot. Right ventricular hypertrophy displaces the PMI to the right. Left ventricular hypertrophy displaces it to the left. Wow, it's a genius move, right? Right displaces right, left displaces left. And here's the sign. Wow, oh my God, on my heart. For I have understood the large hearts of heroes, says Walt Whitman. Yes, here's this big hypertrophic heart. This is a very huge, thick wall, and this is what gives the displaced point to maximum impulse, because this big displacement is trying to say, I understand cardiac anatomy. The right ventricle is usually much thinner because the pressure in the lungs is lower. The right ventricle is much thinner because the pressure in the lungs is lower. The left ventricle is much thicker because the pressure, the systemic pressure, is much greater. Hypertrophies displace the point of maximum impulse. Let's hear it. So, what do we have here? The S2 is normally comprised of A2, aortic heart sound changing, and a P2, pulmonic sound. A2, aortic sound, P2, pulmonic sound. And normally there's a little bit of variation. There's a little bit of variation that when you inhale, it splits it. And when you exhale, it's less split. But the aortic valve generally closes first. Why does the aortic valve close first? Because the pressure in the aorta is greater. P2 is delayed with inspiration because of increased venous return to the heart. When you inhale, not only does air come into the chest, but more blood comes into the chest. When you inhale, there's not only does more air come into the chest, more blood comes into the chest, and that's how you'll be able to determine that it should normally split because of increased venous return. So there's normally no respiration there. Normally when there's a fixed split, when there's no variation by respiration in S2, this fixed split, this fixed splitting is caused, fixed splitting, no respiratory variation, is atrial septal defect. Fixed splitting is atrial septal defect, and generally speaking, anything that widens the split, that delays the P2, pulmonic stenosis, pulmonary hypertension. Delay P2, pulmonary hypertension. Right bundle branch block. Delays right-sided emptying, delays right-sided closing. Widen the split, delayed emptying, delayed closing. Pulmonary hypertension, pulmonic stenosis, right bundle branch block. Delayed emptying of the right side, delayed closing of the right side. Delayed emptying, delayed closing, splits it wider. Wow, cardiovascular is long, and that is because there's a lot of physical findings. It's not like nephrology. You got about 2 physical findings in the entire specialty, which is you have renal artery stenosis, bruits, and edema. It's not like hematology where you have petechiae and pallor. No, cardiovascular is a physical finding specialty. So you could think of this section as your companion for physiology. When we do skin, it's your companion for pathology and also microbiology as well. So here, this is the cardiovascular physical finding companion set for the step 1 physical findings of physiology. And that also includes pulmonary physiology. Now, hand grip in the cardiac maneuver, I'm putting this again in a special card because often students need this repetitively, that hand grip and amyl nitrate are the opposite of each other. Hand grip increases afterload, amyl nitrate decreases afterload. And the effect of these on the heart is that hand grip is like the opposite of an ACE inhibitor, amyl nitrate is like an ACE inhibitor, and the effect of these on the murmurs are what they do about increasing or decreasing the loudness or intensity. Hand grip is going to increase afterload. So an increased afterload as you press firmly and squeeze a hand, you give them something to grip. Basically the muscles of the upper extremity compress the arteries. And when they compress the arteries, it increases afterload, makes it harder for blood to get out of the heart. When it makes it harder for blood to get out of the heart, it makes regurgitant lesions worse. Now, there's no significant effect on venous return. This is the #1 most common wrong answer. The most common wrong answer is thinking that hand grip is like squatting. Now, squatting increases venous return because thighs are big. Look at the size of your thighs. So the thing is that hand grip doesn't do that because the volume of the triceps is much smaller than the thighs. The other thing is your arms are already draining into your heart most of the time, so they're not filled with blood. You can't bleed to death inside an arm. In other words, a fractured humerus doesn't have enough volume to result in death. A fractured femur does. So a fractured femur, you can basically die by bleeding out into your thighs. Motor vehicle accident, bilateral femur fractures. Oh, it's horrible, man. It's horrible, horrible. You could put a leader in each thigh. It's terrible. I don't even like thinking about it. Like, I'd gross myself out. I hate that. I was going to get rid of all death because I just can't handle it. It's just disgusting. So the thing is, though, there's no effect on the heart of hand grip in venous return. Not in venous return because the veins are just smaller than those of the legs. Now, amyl nitrate is an arteriolar dilator. It's a smooth muscle dilator. Nitrates are smooth muscle dilators. That's why we use them in coronary disease. That's why we can use them in Prinzmetal's angina. That's why we use them in Raynaud's sometimes. That's why we use it in esophageal spasm. We use it in esophageal spasm because nitrates are a smooth muscle dilator. And when you do a smooth muscle dilation, it simply dilates the vessels, and so forth. It increases the size of those vessels, therefore decreasing afterload. It's like giving an ACE inhibitor. So since it decreases afterload, regurgitant lesions diminish with amyl nitrate, and regurgitant lesions increase with hand grip. Period. And that's it. Hand grip will lessen aortic stenosis because when you increase the pressure in the aorta, blood can't get out, and you decrease the murmur of aortic stenosis by making the aortic pressure higher. ACE inhibitors improve regurgitant lesions. Hand grip worsens regurgitant lesions, and that's all regurgitant lesions, no matter whose heart. So one love, baby. Same love, same love. Okay, our next slide is hypertension. That's not a physical finding. Of course it's a physical finding. What do? Find it on astral projection? Yeah, hypertension is one of the most important of the physical findings. Who should be screened? We're not really sure, but we say every visit starting at the age of 18, so all the time. Now, this thing about defining hypertension, this is a slide that actually changed recently. So if what I'm about to say disagrees with books you're reading, it is because the video, what we're doing now, is more current. Because it's easier to fix digital video. Therefore, this stays more up to date than up to date. That's right. So the definition is different in the general population because what is it in diabetes? And basically, what is the cutoff in renal disease? And here, what do you do to start initial therapy with 2 medications? So the change of this is that in the general population, the cutoff for blood pressure is 140/90. We do not teach to the concept called prehypertension because we're not sure what that means. We're not sure what to do about it. And everybody should exercise and eat right and lose weight and stop smoking. So it's not particular to prehypertension. It's like not yelling at your mother. You know what I mean? It's not just because you have prehypertension. You're not supposed to be doing that. So the hypertension is defined as 140/90. And now here's something that may differ from some of your books. That is a change in the not too distant past, because it used to be 130/80, now, and then 130/85, now 140/90. Turns out that you didn't need a special lower cutoff. Now, ACE inhibitors are the therapy for when you have a diabetic, ACE or ARBs in diabetic hypertension. And the hypertension, of 130/80, the lower cutoff does have some value when you have hypertension causing renal disease, when we really want to protect the kidneys. Most likely thing is that USMLE is not going to ask you anything controversial, so they're not going to get in your face about things like the blood pressure cutoffs for diseases where it's a bit controversial. So therefore, the cutoff in diabetes in the general population, 140/90, and maybe 130/80 for people who have renal disease. Now, when you have really severe hypertension, 160/100. When you have really severe hypertension, like 160/100, what you have to do then is you start with 2 medications. You start with 2 medications when you have very severe hypertension, because one medication is highly unlikely to be able to ever control a blood pressure of 160/100. It's very, really unlikely that you'll get one blood pressure medication to control it, so use 2 blood pressure medications when it's really high. What are these things? What is it? The most accurate test? And how do these physical findings change management? Ooh, splinter hemorrhages, Janeway lesions, Osler's nodes, Janeway lesions. And what are those? They are not Roth spots. Roth spots are in the retina. Roth spots are in the retina. Roth spots are in the retina. So since Roth spots are in the retina, those things that look like subconjunctival hemorrhages, you know what they are called, these things that look like subconjunctival hemorrhages? They're called subconjunctival hemorrhages. And all of these are findings of endocarditis. Splinter hemorrhages in the fingernails, Osler's nodes raised and painful, Janeway lesions are flat and painless, and these are the embolic findings of endocarditis. All of these things. Well, it looks like a multiple choice question, but the answer is all of them. Okay, they're all found in endocarditis, as they're saying what's in picture A, picture B, picture C, and with positive blood cultures. The blood cultures are first. This is a photograph of the veggies. Those are the vegetations. Those are the vegetations that would be found in endocarditis. So the vegetations of endocarditis are embolic phenomena, and how they change management is not in most people. If the blood cultures are positive and you have vegetation, if you have blood cultures positive and you have vegetation, if you have blood cultures positive and you have vegetation, if you have blood cultures positive and you have vegetations, it doesn't change anything. because you still need to give 4 to 6 weeks of antibiotics. You still need the blood cultures to be negative. It doesn't change anything. They're not an indication for surgery unless they continue to happen while on antibiotics. They're not a change only if they continue to happen. Now, a small number of people, 1%, 5% of people, have negative blood cultures, a small number. So they can be useful to help you diagnose. They're useful to help you diagnose people with endocarditis in the small number of people who have culture negative endocarditis. So in those people who have culture negative endocarditis, okay, small number of people, okay, what you do is a fever, a risk, an embolic phenomena, emboli, fever, risk, fever, emboli, fever, risk. Those three things together and a vegetation on the heart valve can be the diagnosis of endocarditis. So these embolic phenomena can be signs of endocarditis, and they make a difference if they continue to happen while on antibiotics or if the cultures are negative. The other reason they make a difference is so you have to identify them on step 1. Cardiovascular. What is that? Looks like jugular venous distension. What's it associated with? Congestive heart failure. This is cardiovascular section, and you don't know the answer? Say echocardiogram. What do you do when you have jugular venous distension? You're so filled with fluid. Let's diurese you. It's jugular venous distension, and it's a sign of congestive heart failure and valvular disease, all of them. All valvular disease can present with jugular venous distension and CHF, so all congestive heart failure, and it is just a sign of all things that make it hard for blood to get back into the heart. A tension pneumothorax and constrictive are rare causes. All of these, tension pneumothorax and constrictive, can all do it. These are all do it, as well as tamponade. They're rare, but they do cause congestive failure and jugular venous distension. Much more common, out of control CHF. Now, the most accurate test of the heart, generally speaking for this, is going to be an echocardiogram. Catheterization, not necessary. Now, the treatment is based on the cause of these, and so for almost all of them, the answer is a diuretic. But it's a good sign of asking you, do you understand the anatomy for step 1? That's why you got to know about it. You got to know about it because it says, I need to be able to understand the anatomy for step 1, USMLE. Complex level 1. What's the difference? Is there a different blood vessel in complex, like osteopaths have like 6 extra vessels or something? I don't think so. So saying the jugular veins going into the subclavian and innominate and subclavian into the superior vena cava. So see, jugular venous distension can be a anatomy question. Oh, jugular vein. Ooh, facial vein draining into it. It's the anatomy question, okay? The anatomy question, that's what it's for. It's a test of anatomy. Kussmaul sign, what's that? Kussmaul got around, didn't he? Kussmaul breathing, Kussmaul sign. Kussmaul was a contemporary of Charcot. Kussmaul described polyarteritis nodosa too. Kussmaul. So he was a very prominent guy actually in his day. And Kussmaul's breathing is fast, rapid breathing. That's like diabetic ketoacidosis. Okay, Kussmaul's breathing. Can you imagine a guy described heavy, deep breathing and he put his name on it? So he saw 2 people getting laid and he's like, you two. That's my breathing. Kussmaul. Every time someone breathes like that, that's my breathing. Wow, that's amazing, really? So what's the Kussmaul sign? The Kussmaul sign is most likely to be associated. This Kussmaul sign is a jugular venous pressure finding. Kussmaul sign is a jugular venous pressure finding. And Kussmaul sign is associated with a pericardial disease. And the most accurate test of pericardial disease, if it's anatomic pericardial, is a scan. Kussmaul sign is an increase in jugular venous pressure on inhalation. It's an increase in jugular venous pressure on inhalation. That's what Kussmaul's sign is. Now, Kussmaul's breathing is deep, heavy breathing. Normally, jugular venous pressure should jugular venous pressure when you inhale. Oh, you know what happens? Is that normally what happens to jugular venous pressure when you inhale is that the decreased pressure in the chest, the low pressure in the chest, should literally suck blood into the heart. The low pressure in the chest should suck blood into the heart. But when your heart is encased, has your heart grown so small? Like the Grinch who stole Christmas. Should have a heart one's 2 sizes too small. But that's what Kussmaul's sign is. Kussmaul's sign is the Grinch, man. It's like a guy whose heart is 2 sizes too small, encased in a stiff pericardium, that when you inhale, the normal jugular venous pressure should decrease, and now here it increases and goes up. That's the abnormality. Kussmaul's sign is associated with constrictive pericarditis, which is like wearing underwear 2 sizes too small. And on inhalation, what happens is that the tight pericardium doesn't allow for blood to return to the heart. Rises. Doesn't allow for blood to return to the heart, so the pressure rises. The most accurate test for the constriction is to scan the heart, because constrictive pericarditis is a sign of an anatomic abnormality of the heart where it is encased abnormally, and that anatomic problems are diagnosed with anatomic tests. The thickened pericardium, the thickened pericardium, the thickened pericardium that calcifies, there's the heart, there's the heart. There's the thickened pericardium that calcifies. Ooh, there it is again. Fantastic. So here's the anatomy and pathology questions. The anatomy and pathology of constrictive pericarditis is being shown by X-ray. So Kussmaul's sign clinically? Kussmaul's sign for understanding the physiology. Decreased intrathoracic pressure normally pulls blood into the heart. Abnormally builds back up here. Pathology, calcification, most commonly tuberculosis. Anatomy, where is the calcified pericardium? How do we test the anatomy? Imaging scans, imaging and scans, imaging. Oh, I'm having fun. So, allowed P2. Oh, screw off. Don't bugger off, man. Don't make me learn this stuff. Well, allowed P2 is the second component of heart sounds. The P2 is a second component of heart sounds. So when the allowed P2 is described, what's the diagnosis? In the care, the most accurate test. Well, it's a cardiac thing, so it must be echocardiogram. Looking for cardiac things, loud P2, extra loud, second heart sound, like slamming the door. Slamming the door. Is slamming the door, it's from pulmonary hypertension, man, because the second heart sound should be made up of the aortic sound and the pulmonic sound, the aortic sound, the pulmonic sound, and when you have an extra high pulmonic pressure, it slams that door and you get a loud P2. So the second heart sound with the loud P2 is a sign of things like pulmonary hypertension, pulmonary artery hypertension. Mechanism. Endothelin overgrowth, there's the pharmacology. Endothelin antagonist, ambrisentin, bosentin, ambrisentin, bosentin inhibits endothelin in the pulmonary artery, because pulmonary artery hypertension gives a loud P2. Now the etiology is pulmonary hypertension from multiple pulmonary emboli, clogging me up. Mitral stenosis, but that's on the left side of the heart. Yeah, but the final destination of the right heart circulation is the left side of the heart. The final destination of right heart circulation is the left side of the heart. Back pressure, back pressure, back pressure. All these are saying back pressure into the heart. Where you hear things. Oh, APTM, aortic, say? Oh, aortic, pulmonic, tricuspid, and mitral. Sorry, I forget what side I am now. It's mirror image, right? Aortic, pulmonic, tricuspid, and mitral. Yeah, it's hard in background, so I feel like scratching my shoulder by reaching through my fly here. Okay, so the point is where do you hear these murmurs? Where do you hear these murmurs? Okay, and that's the location, the anatomic locations. This is a must-know subject for this. Don't walk into step 1, step 2, or step 3 without knowing these. And step 4, which is the internal medicine boards. Well, also, let me give you the good news. If you get this now, you're never going to have to learn it again. And you may be thinking that because of the increased use of technology in the hospital that we'll be letting go of you needing to know physical findings, but it's not true. It's not true. Okay, so the increased physical finding knowledge, it's not going to go away. Now, I know very well, because I know how attendings round. They round from the doorway. They don't go to the bedside very much. Instead of saying, did you hear a loud P2? They go, yeah. What's the echocardiogram show? And I understand that. But you know, just because it's not done doesn't mean you don't have to know it. Wide splitting of that P2, wide splitting and loud P2, pulmonary hypertension, pulmonic stenosis, and the wide splitting right bundle branch block. Delayed emptying, delayed closing. And it's very close to the same things and more that make the P2 loud because it bashes the door. This is sign of pulmonary hypertension. Sign of pulmonary hypertension. You see, the hilum, the blood vessels in the center of the chest, when they hypertrophy out both ways. And also, mitral stenosis can straighten the left heart border. Mitral stenosis can straighten the left heart border, can give a double bubble behind the heart, straighten the left heart border, double bubble behind the heart. And what happens with mitral stenosis is that the back pressure makes the pulmonary arteries extra big and prominent. And that connection of mitral stenosis making the blood pressure higher in the pulmonary artery is a must-know subject. Mitral stenosis increases pulmonary hypertension. Bang, the P2. Now, the loud S1. By the way, you know why they're called S1 and S2? It just means sound. Sound 1, sound 2. So a loud S1 is something, the loud S1 is in the stem, the diagnosis for loud S1 and the mechanism is. Well, remember a loud P2. When you had a loud P2, we said it was pulmonary hypertension, pulmonic stenosis, raising the pressure. Well, here, this is the sign S1 of tricuspid and mitral valve closing. So now an echocardiogram is always the most accurate test in anything in cardiology of the heart, anatomically, just about. So a loud S1 is something that happens. MDM means mid-diastolic murmur. Opening snap, mid-diastolic murmur, opening snap, mid-diastolic murmur. Okay? So this loud S1 is something that can be caused with mitral stenosis because the pressure is extra high in the right atrium. In the left atrium. The mitral stenosis makes the pressure extra high. And also, anything that does a shortened PR makes the mitral valve close earlier or later. Short PR. Short PR. Short PR. The PR. Also, if you are looking at this material and you've not studied before, you remember that you can't review something you never knew. You should stop the video and go look it up, come back to it, because here we're condensing all physical findings for all diseases, and I mean all diseases, and I mean all physical findings. You mean there's only 200 of them? The truth is there's not even really 200 of them. Actually, when you go, I just picked 200 because it's a nice easy number. It's a nice easy round number. 200 tests, 200 physical findings, 200 groups of drugs. And there's about 200. So it means that you can learn all physical findings in all diseases, in OBGYN and in psychiatry and in cardiology, pulmonary, GI, in 200? Yeah, that's the fact. That's the fact. So, but a short PR, if you're not familiar with it, is things like Wolff-Parkinson-White. Wolff-Parkinson-White is a short PR. It's also called pre-excitation syndrome. Now, a pre-excitation syndrome means the ventricle depolarizes early or depolarizes late. Depolarizes early. It's a short PR, fast. So you see the mitral valve is already open, still open. Mitral valve is still open. So instead of the nice normal flop, flop, the ventricle contracts and goes bang, bang. That's why short PR causes a loud S1. Anything that causes premature closure, bang, bang. Things like mitral stenosis. The mitral valve is open, the ventricle contracts while the mitral valve is still open, and instead of the nice flap, flap, it closes with a bang, because the stenotic valve is still abnormally open. Here, mitral stenosis. Take a look. Can you figure it out? Well, the reason why the volume in the disease goes down, because the red is the diseased, is because it can't fill. So since it can't fill, it tends to move over. It's moving over. Okay? Can't fill. It can't fill. So the volume is less. Normal volume, diseased volume. Normal volume, diseased volume. Normal volume, diseased volume. It can't fill. Normal volume, diseased volume. Because it can't fill. So the left ventricular pressure is not up or down. It's the left atrial pressure that's up. But you can't fill, so it decreases cardiac output. Now, all valvular lesions present with shortness of breath. They can. All valvular lesions can present with shortness of breath. All valvular lesions. All valvular lesions give congestive failure. All valvular lesions can give congestive failure. But they don't all give a loud S1. Calcification and fibrosis gives a loud S1. And this slams that valve shut, making it close abnormally high pressure with an abnormally high pressure. The same thing in the short PR, it contracts prematurely while the mitral valve is still open. And that's why the most accurate test for all of these tends to be the echocardiogram. The mitral valve won't allow filling, so the left atrial pressure is up. The mitral valve won't allow filling, so the left atrial pressure is up. Now, it doesn't change the left ventricular pressure. LVP means left ventricular pressure, but the atrial pressure is up, and that's why we have all these illnesses, because the left atrial pressure is up, that dilates the atrium. Atrial pressure is up, dilated left atrium. Atrial pressure is up, dilated left atrium, more AFib. More AFib, more stroke. More dilation, more dilation, more AFib, more stroke. Dysphagia, because the left atrium presses against the esophagus. Dysphagia, as it presses against the esophagus and dilates. Oh, the opening snap, mid-diastolic murmur. Opening snap, mid-diastolic murmur. This is not going to go away. It's not going to change. One, you're going to have to know. Two, if you learn this now, you're never going to have to go back. You're never going to have to go back. And doesn't that help you explain why mitral stenosis has the most amount of dysphagia, enlarged, press of the esophagus, most amount of AFib, the most amount of stroke? Gets worse in a pregnant woman because the pregnant woman increases her plasma volume so much. All fits together, doesn't it? Opening snap and murmur. Next heart sound. What do you hear? So we have a 64-year-old woman who comes to the office. She's got exertional short of breath and hemoptysis. Well, that doesn't narrow it down. All cardiac valve lesion can give you shortness of breath. Hemoptysis tends to be something that causes cause of pulmonary hypertension. And a holosystolic murmur is heard. Holosystolic, that's the holosystolic. And what's the difference between holosystolic and pansystolic? Holosystolic and pansystolic. Holosystolic and pansystolic, and the answer is nothing. See, a holosystolic or pansystolic murmur is mitral regurgitation because it obscures both S1 and S2. Mitral murmurs go to the axilla. They go to the axilla. Carotids to the aorta, mitrals to the axilla. Okay? And the most common, that's where it radiates. That's where is it radiating. The most common cause is anything that dilates the heart. Dilated cardiomyopathy, hypertension and ischemia. Hypertension and ischemia, the most common cause. It's back to hand grip Valsalva and our old friends, auscultatory maneuvers. But you can't intimidate me now, auscultatory maneuvers. I have mastered you. No me jodas, coños. Okay, so this is the failure of the mitral valve to close, so blood regurgitates backwards. The failure of the mitral valve to close, so blood regurgitates backwards. With the failure of the mitral valve close, it backflow into the left atrium. Backflow, very good, it dilates. Remember, dilation equals regurgitation. So mitral regurgitation or insufficiency, holosystolic, pansystolic are the same thing. Mitral regurg, mitral insufficiency are the same thing. It obscures S1 and S2. That's why it's called that's why it's called pansystolic. It's heard better when you're leaning forward. When you're leaning forward, you bring your heart towards the chest. You bring your heart towards the chest. You bring your heart towards the chest, and you hear it more. And it radiates the axilla as regurgitant murmurs do. Here's a different representation. Pause and absorb. Oh yes, obscuring S1 and S2, and this is the extra left atrial pressure. Sure, it's extra left atrial pressure because it's regurgitating backwards. Look, it's extra left atrial pressure because it's regurgitating backwards. There's extra. 10, 25, 10, 25. It's regurgitating backwards, extra left atrial pressure, dilated cardiomyopathy, AFib. So anything that causes you to kill off the heart, it gets wider. Ischemia kills off the heart, gets wider. Endocarditis makes the valve incompetent. Incompetent valve overstretches. Rheumatic fever can cause any of them. Rheumatic fever is very rare in the United States because we treat all these throat infections with enormous amounts of antibiotics. So therefore you will see very little rheumatic fever. So rheumatic fever is basically, although it causes any of them, it causes mitral stenosis the most often. Mitral valve prolapse regurgitates, but when it's from prolapse, you have different symptoms. That's basically chest pain and palpitations. But remember, the prolapsing heart valve, when it doesn't fit together, the prolapsing valve is incompetent and it regurgitates. Oh, hand grip increases the afterload. You squeeze the arteries of the arm and it shoves the blood backwards. Hand grip. The opposite of hand grip is amyl nitrate, which dilates the arteries. So hand grip is the opposite of an ACE inhibitor. Amyl nitrate is the same as an ACE inhibitor in terms of amyl nitrate vasodilation, and decreasing afterload. So amyl nitrate softens all left-sided murmurs except mitral valve prolapse and hypertrophic obstructive cardiomyopathy. Valsalva decreases venous return. Less blood, less murmur. Increased intrathoracic pressure decreases venous return. Squatting does the opposite of Valsalva because when you squeeze the leg veins, squeeze the leg veins, squeeze the leg veins, you are increasing venous return because your thighs are bigger. This is not repetitious by accident. What do you hear? Oh, we heard a pregnant woman having more shortness of breath. Let's hear, okay? Hear that as many times as you want. It's a very complicated murmur because it's a diastolic, mid-diastolic murmur. Pregnant women increase plasma volume. The increased plasma volume worsens a couple of things. It worsens stenosis the most. Hemoptysis is a sign of pulmonary hypertension. Telling you that she's an immigrant to the United States from places with less health care means rheumatic fever. This is the opening snap, and this is the mid-diastolic murmur. Opening snap, mid-diastolic murmur as the blood squeezes through the heart. It's an immigrant, meaning to tell you rheumatic fever is an imported disease. If you can afford a few pennies for penicillin for your kid's strep throat, you won't have rheumatic fever and you won't have mitral stenosis. Now, this is mitral stenosis murmur, and it's most likely caused by rheumatic fever because almost nothing else will do it. That's why we'll give you an immigrant. All valvular disease causes shortness of breath. All valvular disease causes edema, dyspnea on exertion, jugular venous distension. That's all valve disease. But all valve disease does not have dysphagia, hoarseness, and all that strokes. Valsalva decreases venous return. Squatting increases venous return. Less blood, less murmur, more blood, more murmur, except HOCM and mitral valve prolapse, which are the opposite. What will happen to the extra heart sound, okay, the opening snap, as this worsens? Does the opening snap happen earlier or later? The opening snap, what's going to happen? The opening snap, look at the timing of the opening snap. Will it happen earlier as it gets worse or later? What opens the valve? Ooh, what opens the valve is pressure in the, this is the mitral valve. What opens the mitral valve is pressure in the left atrium. When the disease gets worse, does left atrial pressure get worse? Yes, it do. Worse disease, it opens earlier. Look, mitral stenosis has an opening snap, and that opening snap gets earlier, happens earlier when the disease gets worse because left atrial pressure goes up. Now, mitral stenosis is most likely from rheumatic fever, which causes fibrosis. That's why you can balloon it. You can balloon it because it's fibrosis. You can balloon it because it's fibrosis, and that's why it pops. You can't balloon aortic stenosis because it's calcification, it's sheetrock, it's bony. But mitral stenosis is fibrosis, and the fibrosis can stretch. If you're a guy and your mother sends you underwear that's 2 sizes too small, what would you do with it? Men don't return clothes. What do? You probably give it a stretch and wear it. Too fibrotic. Underwearoplasty. And that's why here, mitral stenosis, you can balloon it. Now, here, massive enlargement of the left atrium. Big massive enlargement of the left atrium. That gives pulmonary hypertension. Pulmonary hypertension gives hemoptysis. Massive enlargement in the left atrium gives you AFib. More AFib, more emboli. More AFib, more emboli. Big atrium presses against the esophagus. Dysphagia. Pressing against the recurrent laryngeal nerve. You see, you get this once now, you're never going to have to learn it again. It's going to stay permanent, and you're never going to have to come back this way again. Valsalva decreases venous return because increased intrathoracic pressure, exhalation against the closed glottis. I just soiled myself. And squatting increases venous return, more blood, more murmur. Less blood, less murmur. Except HOCM and mitral valve prolapse. So as the mitral stenosis worsens, the opening snap happens earlier. And it happens earlier because the left atrial pressure goes up as the valve lesion worsens. Echo, cath, balloon. What do you hear? Young woman with the click. Most of the time she's not too sick. Palpitating, levitating, and a mid-systolic click. Palpitating, pain, and panic attack. Palpitations, and the answer also is just found. It's just found. What caused most mitral valve prolapse? Mitral valve prolapse is a 1980s disease, really. It's like big hair bands. Here I go again on my own. You know, you know what I mean? It's like, I don't want to insult Kiss, but it's sort of like that, you know what I mean? But the thing is, mitral valve prolapse was invented by the echocardiogram. Once we invented echocardiograms and they became everywhere in the 1980s, everybody got mitral valve prolapse, because it turns out that mitral valve prolapse, with that click, was asymptomatic. And then you got palpitations, and it's like young ladies with palpitations, and you found the click, and you found the mitral valve prolapse. And mitral valve prolapse, most of the time, is just the normal anatomic variant, and most of the time it's not symptomatic. If it's not symptomatic, don't do anything about it. Okay, all mitral valve prolapse, like all regurgitation, is heard at the axilla, radiating, okay? Heard the apex going to the axilla, 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 apex going to the axilla, because it's regurgitation. Now, the most common presentation, well, most people are asymptomatic, but when you are symptomatic, it's palpitations and what's called atypical chest pain. Typical chest pain is I go walking, and ay, Dios mío, ay, doctor, ay, yo tengo mareo, ay, que lástima, ay. That's typical pain. Atypical pain is, how you doing? I feel fine. And you just have pain. Typical is on exertion. Atypical is just happens. Atypical pain. Atypical pain. It just happens. You don't know which question you're going to be asked. And so the point of this methodology is it's very important that you understand that you have to be prepared for any one of these questions. That's the point of what's writing here. If they ask you this presentation, diagnosis, mitral valve prolapse. Cause, you say idiopathic most of the time, myxomatous generation, loose and floppy valves. The presentation, asymptomatic, and what is symptomatic, palpitations and pain. The auscultatory maneuvers can be difficult because for mitral valve prolapse and HOCM, it's the opposite effect of all the other valve lesions. Hand grip will actually make it better because hand grip prevents blood leaving and makes the heart bigger. Anything that makes the heart bigger makes the valve fit together better. There are some sources in places that are incorrect. They say the opposite. I forgive them. I forgive you. Mafkia, 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 bapu. Okay, I forgive you. Hand grip tends to improve it. Valsalva makes the heart small. Anything that makes the heart small, it gets worse because the leaflets don't fit. Squatting makes the heart big. Bigger heart makes them fit. Amyl nitrate increases dilation, makes it dilate. Arteries dilate, makes the heart smaller. This will become clear in a second. Do you need to use endocarditis prophylaxis? Actually, it may seem oddly out of place here, but I just happen to know what one of the most frequently asked questions are, which is that you should know that, you know, and you don't need endocarditis prophylaxis anymore with mitral valve prolapse. You don't need it, just don't need it. Now, no matter what procedure you're undergoing, you don't need endocarditis prophylaxis for mitral valve prolapse. And it's just a very common question, so let's not screw it up, okay? So here's our friend, the heart, and a prolapsing valve means extra floppy, extra loose tissue. Prolapsing means it's floppy and going backwards. See, when the ventricle contracts, it's floppy and goes backwards. And the mitral valve prolapse, the click is the sound of those leaflets stopping short. It's the sound of those leaflets hitting and going pop, stop, click, click, click. And sometimes, if it really doesn't fit together well, it'll leak and that'll have regurgitation. So you just get extra floppy valve leaflets. Now, most of the time it just happens, and we don't know why. So like all regurgitant lesions, it's heard at the apex and radiates to axilla. This is prolapse. It's flopping backwards the wrong way. See, the ventricle's contracting, and the leaflets are going the wrong way. The ventricle's contracting, and the leaflets are going the wrong way. And it's billowing out there, and then they see the space. That's what makes them leaky and regurgitant. The click is when the leaflets stop short. Anything that makes the heart smaller makes them not fit. Anything that makes the heart bigger, they fit. Small heart, they don't fit. Big heart, they fit. Let's try it again. Small heart, they don't fit. Big heart, they fit even nice and evenly. Small heart, leaky. Big heart, tight. That's why the maneuvers are the opposite of all of the others. Now, palpitations, atypical pain. Remember, typical is on exertion. Atypical just means anywhere. Why has it been associated with anxiety? It's not even clear. It's just a testable association. And most of them are, in fact, asymptomatic. The smaller the heart, the worse it is. The bigger the heart, the better it is. Valsalva and standing make it smaller. Valsalva and standing, by decreasing venous return, worsen it. And the click gets worse. Small heart, click worse. Nice picture, huh? Oh, look, there it is. That looks like the prolapsing valve, doesn't it? God, I love it. Looks nice. So the click happens later when the heart gets smaller. Squatting, which increases venous return, does the opposite and makes it better. Amyl nitrate makes ventricle empty more. Anything that empties the ventricle more, makes the heart smaller. Small is leaky for prolapse. Smaller is leakier for prolapse. And endocarditis prophylaxis, it's just not needed because you have very low risk. And this is a fantastic picture of the murmur of mitral valve prolapse that basically, okay, when you put the leaflets, the smaller or bigger, it changes the effect when you have a smaller or larger heart. Let me get out of your way, and I'll see you in the next section. Hey, well, time to have a good time with cardiovascular physical findings. Conrad Fisher. Listen to the sound. All right, what is it? ¿Qué es eso, huh? Well, it's a young man who comes to the office, got a routine screen. Well, what does that mean? Chlamydia? You know, so the point is, what heart sounds, besides S1 and S2, can be heard in basically a healthy young man? And there's not that many things, because S4 is not a normal anatomic variant. S4 is hypertension, hypertrophic cardiomyopathy. And a murmur, not too much, but did you know that you can hear an S3? An S3? That was what that was. That was an S3 gallop. An S3 gallop can be a normal anatomic variant in a young, healthy person. It's the sign of rapid ventricular filling. It's an extra heart sound, that X, okay? It's most likely an S3 gallop, and the effect of inspiration on right-sided lesions. Now, by the way, okay, we're not saying that the sound is a right-sided lesion, but in general, right-sided lesions increase when you inhale. The effect of exhalation is left-sided lesions increase when you exhale. Right increase when you inhale, left increase when you exhale. And the significance of an S3 gallop in a healthy young man is nothing. That's the point. It's a normal variant. And step one and USMLE and our boards are very interested in having us protect our patients from too much testing. So what you're not supposed to do is order stress tests and echocardiograms on the person. You're supposed to know that an S1 and S2, the only other things you can hear in a normal heart sounds is to hear an S3 gallop in young healthy people, particularly athletic ones. Right-sided lesions increase in intensity when you inhale because inhalation increases venous return to the right side of the heart, and exhalation increases venous return to the left side of the heart. And that's why you can have a little splitting when you inhale, because when you inhale, you're increasing venous return to the right side of the heart. Here's that S3, lub-dub, very scientific, don't you think? There it is. It's a sign of, what is the mechanism? When the mitral valve opens, and then there's rapid ventricular filling. That's the step one question. What is the mechanism of that S3? Rapid ventricular filling. What is the mechanism of that physical finding? What is the mechanism of that physical finding? Rapid ventricular filling on mitral valve opening. And this is when you increase venous return to the right side of the heart, when you inhale, exhalation increases it to the left side of the heart as you squeeze the lungs. And S3 is normal in young people. It goes away. And if it comes back, it's worse. Now, an S4 is atrial systole into a stiff, non-compliant ventricle. S4 is atrial systole into a stiff, non-compliant ventricle that should normally relax and not change pressure. But when you have left ventricular hypertrophy, S4. S3, mitral valve opens and you have rapid ventricular filling. Oh, yes. Our next one, orthostatic hypotension. Orthostatic hypotension. Orthostasis means it's a change in position. It's defined as a drop in blood pressure, 20 points of systolic, 10 of diastolic, 20 points of systolic. And what does orthostatic means? It means your volume depleted. But you have normal blood pressure when lying flat. You have a normal blood pressure lying flat like a hospital bed. And it's a drop in blood pressure when you stand up, and it's meant to detect subtle blood losses, 10, 15, 20%. The next best in the step in the management of anybody who's hypotensive is always fluids. What fluids? What fluids? First, second year medical students are always terrible about which fluids to use. Terrible. So I'll give you the idiot's version. When you don't know what to say normal saline. Yeah, normal saline brings up the blood pressure. Fluids, man. So basically, it's the difference in the pulse and the blood pressure, orthostatic, when you go from lying flat to standing up. Now, your blood pressure should go down a little when you stand up, but it shouldn't go down 20 of systolic or 10 of diastolic. Are you crazy? Shouldn't go down that much. Okay, but when you have a person who's got a blood volume loss or dehydrated or GI bleeding, that's the most important thing. Lying flat, the blood pressure and pulse were normal, you sat them up and all of a sudden you're like, yo, dude, got hypertensive. And that's what orthostatic is. It's a subtle drop in blood pressure that's not detectable when lying flat. Now, it's defined as a systolic drop greater than 20 millimeters or a diastolic drop greater than 10 millimeters. It's a 20-point drop in systolic or a 10-point drop in diastolic, and or a greater than 10 millimeter drop in diastolic pressure. So the pulse goes up or the blood pressure drops. The pulse stays abnormally up or the blood pressure drops. That's what orthostatic means. It means a 15 or 20% volume loss. How much volume loss is a blood donation? A blood donation is only a loss of about 10% of bodily volume. That's a blood donation, only about 10% of bodily volume. So when you go standing up, you shouldn't drop your blood pressure or raise your pulse. But when you've lost 15 or 20%, you have a normal blood pressure and pulse when lying flat, but when you stand up, the systolic drops by more than 20, the pulse goes up by 10, the diastolic drops too. That's orthostatic. It's a wonderful thing. You're going to really know what you're talking about when you get onto the floors and you're walking around. It's really going to make you look smarter if you know what this is. That's why this card set, all of them, the physical findings cards and the farm cards, the diagnostic test cards, remember the ones that are in the bookstores is more just the step 2 and 3 version, and the ones here has everything the cards in the stores have, but adds enormous amounts for step 1. So when arresting pulse and blood pressure are abnormal, well, you got to lose like 30% volume for arresting pulse just lying flat. You got to lose like 30% volume for arresting pulse or blood pressure to be abnormal. But orthostatic is less than half of that, 15%. And that's why it's an important finding. Because if you're waiting for the resting blood pressure or resting pulse to be abnormal, you're going to wait for a colossal blood loss. It's way too much. You give fluids. Orthostasis is to detect a modest amount of blood loss or fluid loss or dehydration where you're normal at rest, but when you change position, your carotids, cranial nerve 9, or your aortic arch, cranial nerve 10, cranial nerve 9, cranial nerve 10, glossopharyngeal, vagus, carried up to the medulla, the carotid signals, okay? The carotid will sense blood pressure, too high blood pressure, too low blood pressure. When the blood pressure is high, do you have increased stimulation or decreased stimulation when the blood pressure is high? When the carotid sense it for high blood pressure, is it increased signals or decreased signals? It's increased signals because these are stretch receptors. They are mechanoreceptors and they're stretch receptors in the carotid. So the signals in cranial nerve 9 go up. Low blood pressure, they're stretch receptors, mechanoreceptors. And the cranial nerve 9 senses less stretch, so the signal goes down. More signal for stretch receptors, less signal for those stretch receptors. They're mechanoreceptors, and basically they measure the pressure and the rate of that change as well. When you and I change position, there is a small change in pulse and blood pressure that should correct itself within 30 to 60 seconds. So if you have a person who has a very fast change in pulse and blood pressure, it will be detected and responded to the rate of the change. The faster the rate of change, the more signal you have. So here again, cranial nerves 9, cranial nerve 10, picking it up from the carotids, picking up from the aortic arch. More pressure, more mechanoreceptors. The baroreceptors are here at the bifurcation of the carotids. That's in the sleeper hold when somebody gets squeezed on those carotid baroreceptors and you pass out. It's in the walls of the carotid sinuses at the bifurcation, and the carotid sinus nerve goes to the glossopharyngeal, cranial nerve 9. There's a good step 1 question for you, to the medulla. Okay, so the location of those baroreceptors, that's when you squeeze it makes people pass out. Press on your own. And it makes people pass out. They basically are little bulbs or dilations that will sense the pressure. More blood pressure means more firing because they are mechanoreceptors, and a faster increase in blood pressure. A faster increase because it checks the rate too. So that's why it is, it says, you see here, the amount of stimulation you have, no stimulation. Blood pressure high, big stimulation. More blood pressure, more reception of stretch of mechanoreceptors. Cranial nerve 9, cranial nerve 10. So the afferent means two. Afferent, is a fancy Latin word for two. Cranial nerve 9, to where? To the carotids or to the brain? So when we say afferents in the neural system, we always mean towards to the central nervous system. And the aortics, the afferents of the vagus nerve. The vagus nerve is both an afferent and an efferent nerve. The afferent means towards what? The aorta or towards the central nervous system. In the neural system, when we say afferent, we mean to the central nervous system, to the medulla. And the medulla then slows the heart rate and dilate. Slow the rate and dilate. Slows the rate and dilate. Slows the rate and dilates when it senses a very high blood pressure. But orthostasis is when stimulation stops. Next one. It's a man with the fever and a murmur. And a murmur and a fever, and a fever and a murmur, and a murmur and a fever, and the lesions are painful and tender. What are they? What is the most accurate test? What are they? Ooh, Fever and a murmur, and a murmur and a fever, and a fever and a murmur and a murmur and a fever. Red and painful and tender. Osler. Osler's nodes are painful and raised and tender, and they are embolic phenomena. Let's look at them again. They are the embolic phenomena of endocarditis. It doesn't matter that they're rare. It matters that you just need to know that if you have culture-negative endocarditis, they help you to make the diagnosis, and they are shown them on step 1. There you go. Osler's nodes are embolic phenomena of endocarditis, flopping off vascular platelet plaques with bacteria in them. Boom, getting caught in those blood vessels, and they're raised and painful. Janeways are flat and painless. Janeways are flat and painless. Osler's are raised and painful. Now, the most accurate test for endocarditis is blood cultures and an abnormal echo. Those two things are the two major criteria to diagnose endocarditis. Now, Vierdens group strep in your mouth. Vierdens group strep. Speciation: Malari Meiteor mutans Salivarius sanguis. Malari Meiteor mutans Salivarius sanguis. All Vierdens group. They all are treated with about the same thing. So Osler's nodes don't tell you which one you have. They are just a sign of the embolic phenomena of endocarditis. Next sound. So, what do you got? An infant. Failure to thrive. An infant not feeding. Short of breath. Oh, see, that's the key word. Continuous murmur. There's not too many continuous murmurs. Continuous means that it's through both systole and diastole. That's what continuous means. Systole and diastole. There's not too many things that are both systole and diastole. Okay, also sometimes called as a machinery murmur through systole. Always leaky. And that murmur is the murmur of a patent ductus arteriosus. Now, you will most likely never meet a human being with a patent ductus arteriosus because they are repaired or closed, either used non-steroidals to inhibit prostaglandins and close them in infancy, or surgical closure, but you'll almost never meet an adult with a patent ductus arteriosus. Okay, but this murmur, the most accurate test for all murmurs, echo. Catheterization can be the most accurate, not necessary, but echocardiography, transthoracic first, transesophageal better. Transthoracic first, transesophageal better, always. Transthoracic first, transesophageal better. Transthoracic first and transesophageal better. Close it! It's leaky. Shut that door. It's cold in here. Now, patent ductus arteriosus is a continuous murmur, and seriously ill children just don't eat. That's what happens when parents call up and they say, I'm so worried, my daughter, she's got like 104 fever, she couldn't sleep, I'm like, oh, is she eating? Well, yeah. Well, is she walking around? Is she active? Is she playing? Oh, yeah, she's running around. Yeah. Well, don't worry about it. Because sick children declare themselves by not eating and not moving. Now, PDA, though, is a baby diagnosis. It's a baby diagnosis that's heard in the infraclavicular lesions, underneath the clavicles. And a thrill is a palpable murmur. That's a murmur that's so loud, so intense, it actually sends a vibration you can feel. It's so loud, so intense, it sends a vibration that you can feel. And if untreated, you get congestive failure and pulmonary hypertension. There's a patent ductus arteriosus. There's that connecting point. There's the connecting point. Now, this is a normal embryonic finding, because remember, we don't want blood going to lungs in infants. I should say inside the uterus, excuse me. So we want to say that we don't want blood going to the lungs when the fetus when the baby is still inside the uterus because you're not breathing. You don't even have snorkeling in there and all that amniotic fluid in the uterus. So we want it to bypass the uterus. We want it to bypass the lungs while in the uterus and go straight from the pulmonary artery into the aorta. Bypasses the lungs because the lungs are squished. Now, when you give birth, when you're born, the pressure inside the lungs goes down and the blood should start going into the lungs and the ductus arteriosus should close. There's nobody walking around with a patent ductus arteriosus because if it's not closed, what you'll do is you do an echo to find it there, to get indomethacin or other non-steroidals to close it up because with prostaglandin inhibition should close it up. And if that won't work, if a non-steroidal won't work, then the answer is surgical closure of it's performed. And you take the itty, oh, you little cutie baby, and you basically take that thing and clip it off, suture it off, close it off. Now, which of the shunts is most likely to be open in an adult? If I just said patent ductus arteriosus is not open in an adult. The one that's most likely to be open in an adult is the foramen ovale. That's the one most likely to be open in an adult. So the left to right shunt can eventually, because remember when you're born, the left to right shunt, it goes left to right. Why does it go left to right? Because the pressure is greater where? The left or the right? The pressure is greater on the left. But what happens eventually is the right ventricle can become so big and so thick that the shunt starts to go from right to left. And what that is, why that means left to right, right to left, I can't understand it, skip it, I don't want to do this, I want to be an orthopedic surgeon. Why this is important is because left to right shunt, right to left shunt, which one of those is more dangerous? Ooh. The right to left shunt is more dangerous because it's deoxygenated blood. The right to left is more dangerous because if you go right to left, if the shunt reverses and it's right to left, that's deoxygenated blood going into your left ventricle and you desaturate. Right to left is deoxygenated blood. That's cyanotic heart disease. So right to left is much worse. That's Eisenmenger's. When a left to right shunt eventually becomes a right to left shunt, and that's Eisenmenger's. What do you hear? What do you hear? What do you hear? What do you hear? Now, ooh, it's a friction rub. Friction rub, a plural friction rub, and pericardial friction rubs. Those are the two kinds of friction rubs we have. They're leathery, velcro-y sounding signs of a plural friction rub. It sounds like Velcro. Like those of you who have hair, take your hair and rub it together. I can't do that. Okay, it sounds like a leathery, scratchy sound, and the patient has pain, pain, pain. Patient has pain, pain, pain. Then they're breathing, breathing, breathing. Pleuritic pain, pain, pain. And the cause of friction rubs is infection. The infection often, sometimes uremia, sometimes lupus, but usually infections in there. And when you see a rub in the case, it's often an infection with the two parts of the pleura, with the visceral pleura and the parietal pleura, the visceral pleura, the parietal pleura, the visceral pleura, the parietal pleura get inflamed and start rubbing against each other. Pleural rub. Now, everything I just said about pleural rub, you actually can apply the same terms to the pericardial rub. The pleural and the pericardial rub largely has the same findings in terms of a Velcro, leathery sound rubbing against each other, just like the sound I showed you. And it's in timing with respiration. So that's one of the ways you can tell it's not a pericardial rub. Because if you said, hey, fishy, 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 you just said plural pericardial rubs sound very similar. How am I supposed to tell it's not a pericardial rub? The answer is pericardial rub is going with the heart rate. But pleural rub is in timing with inspiration and expiration. That's how you'll tell the difference because of the timing. Stop breathing, it should go away. Because pathology, nasty, nasty lungs. So this is the gooey. It has a certain, I don't know what. So it's sharp pain that gets worsened by respiration. That's what means pleuritic pain. Okay, and pleuritic pain gets decreased by splinting. Splinting means that you don't breathe in that side. For instance, if you have a pleural rub on one side, you end up leaning towards that side and you start breathing on the other side. And the problem is that not breathing on the side, not breathing on one side, leads to atelectasis. Splinting is like guarding. Guarding means don't touch me, don't touch me, don't move, don't move. It's like guarding. And what ends up happening is that you get pneumonia after the atelectasis. So the patient has decreased breathing on the side of the rub, and this leads to atelectasis pneumonia the same way it does when somebody has a rib fracture. Rib fractures do exactly the same thing. Our next slide, card 26. Remember, these slides that we're doing here in the set is in the same order as the cards in the box. So what you should be doing is read the card in the box, then watch the video. That will help you to get the maximum out of this. And you can carry them around with you and take notes. Pericardial knock. What a great sound. How poetic, a knock. What is it? No, I think it's a knock against the pericardium, isn't it? A pericardial knock is in the question. It means constrictive pericarditis. And the most accurate test for constrictive is actually not an echocardiogram, CT, MRI. MRI, CT is the most accurate. The pericardial knock is the sound as the ventricle fills, bang, it hits the pericardium. As the ventricle fills, bang, it's the pericardium. As the ventricle fills, bang, it's the pericardium. Ventricular filling and hits the pericardium with a knock, pericardial knock. So a third heart sound in diastole as it's filling. And because as it becomes full, it can't expand in diameter because it's a calcified fibrotic pericardium. And that calcified fibrotic pericardium, it hits with a knock and makes it so that it is an extra sound when it stops filling. Because it hits the pericardium. So now, as it starts, okay, and then what happens is massive drop in Y descent, because after the heart empties, and then it comes time to fill again, that there's a precipitous drop in the pressure because it's the knock sound and then a precipitous drop in the pressure and that exaggerated Y descent. There's the step one question for you. What is characterized most on venogram, on venous pressures, on jugular venous pressure, the pericardial knock? And the answer is an exaggerated Y descent after the heart empties. Drops. Now, constrictive pericarditis has to be from chronic inflammation. Here's the pathology question. Tuberculosis, fungus, chronicity, fibrosis, fibrinoid necrosis, tightening. And it tightens it up. The most accurate test of constrictive pericarditis is the anatomic tests like a CT or an MRI are the most accurate thing because you're seeing thickening and calcification to be able to detect the abnormal fibrosis and thickening. This is constrictive pericarditis on a drawing. This is it on a CT, and it calcifies, MRI, calcifies up there on the pericardium, and the only way to fix it is to remove it. There's no medical therapy really. We can use a diuretic, but a diuretic that's just symptomatic relief. If you're really all tightened up around your heart to the point where you can't breathe, if you're tightened up around your heart to the point where you can't breathe, you better remove that. That's like closing your penis in the zipper of your pants. I can't even believe I say things like that. It's disgusting. I hate myself. So the pulsus paradoxus, what is it? Now, we don't have a picture of a pulsus paradoxus because it's a blood pressure finding. A blood pressure finding because it's an exaggerated drop in blood pressure on inhalation. That's the definition. An exaggerated drop in blood pressure. Everybody's blood pressure will drop when you inhale, but it shouldn't drop more than 10 millimeters of mercury. But it does in a pulsus paradoxus. The most likely diagnosis with a pulsus paradoxus is pericardial tamponade. Pericardial tamponade in the pulsus, and the initial therapy is fluids because you want to fill up the heart so you can actually push open that effusion, that pericardial effusion, by pushing open the heart. Now, pulsus paradoxus is when you inhale, you have a drop in blood pressure more than 10 millimeters of mercury on inhalation. Now, everybody's blood pressure drops a little because when you inhale, what fills? The right side of the heart or the left side of the heart when you inhale? When you inhale, what fills? The right side of the heart or the left side of the heart? When you inhale, the right side fills first. And normally the heart just expands in external diameter. Normally the heart just expands in external diameter. But when you are encased in tamponading fluid, the heart can't just expand in external diameter because it's been encased. And that's why the blood pressure drops. So what's the paradox? Is that when you inhale, an intrathoracic pressure drops and you fill the right ventricle. The blood pressure here drops so much that the pulse can actually disappear. And that's the paradox. You inhale, systolic pressure goes under 90, pulse disappears. You exhale, the pulse came back. You inhale, and there's a big drop in blood pressure. Systolic less than 90. When the systolic goes less than 90, you don't have a radial pulse. You exhale, the blood pressure comes back and you feel the pulse. You inhale, and the right ventricle gets big. You inhale, the left ventricle gets small. The problem is you live off of your left ventricular output. You inhale, the right ventricle gets big and compresses the left ventricle to the point at which the pulse disappears. And then it comes back. So your pulse is gone, but you're still alive. That's so paradoxical. That's pulsus paradoxus. Right ventricle enlarges, left ventricle gets smaller, blood pressure drops, and the pulse goes away. Beautiful, isn't it? Now, a pulsus paradoxus, now it is true that you can have it in asthma, but the biggest point for you is that you understand that when the heart is compressed, it happens the most often. The others are less common here, and they don't need them. You don't need a pulsus paradoxus to diagnose asthma, where you can hear the wheezing. The bolus of fluids is to push the the heart open so you don't have hypotension. All hypotensions are treated with fluids. And this is the respiratory variation. Big complexes, small complexes, big complexes, small complexes, but it's exaggerated because the heart is flopping forward and backward and forward and backwards in the chest because it's in a bath of fluid. And then when the heart flops forward, the complexes get bigger. When the heart flops backwards, the complexes get smaller. When the heart flops forward, the complexes get bigger. The heart flops backwards, the complexes get smaller because the heart is physically distant from the anterior chest wall. The leads are here. If the heart flops away from it, the impulses go down. When the heart flops towards it, the impulses go up. Pulsus paradoxus, and this is called electrical alternans. That's a very important EKG finding because tamponade, if you have it and you don't put a needle in that chest to suck out the fluid, you die right away like that. Now, the earliest finding of tamponade is what? What's the earliest finding? Even before pulsus paradoxus, The earliest finding is right atrial and right ventricular diastolic collapse. That's the earliest finding of tamponade, is right atrial and right ventricular diastolic collapse. Now, here we go. Pulsus parvus et tardus. You should use this for yourself like this. As gee, you're small and you're late. No, I'm not small and late. I'm parvus and tardus. Okay, that's what that means. Parvus and tardus. That's where we get the word parvovirus, the smallest virus there is, smallest DNA virus. Parvovirus, because it's parvus, smaller. Tardus means late, like you're tardy. Okay, so that is basically small and late pulse. And the most likely diagnosis is aortic stenosis. The most accurate test for aortic stenosis, echo, cath, echocardiogram, cardiac catheterization. Cardiac catheterization, rarely necessary, and 99% of the time diagnosed off of echocardiography. Cath is the most accurate though. It literally means that the pulse is diminished and late because there's aortic stenosis in the way. So the pulse is blocked. That's a fancy word for blocked pulse in the carotids. Aortic stenosis blocks the ejection of blood, and the pulse is late and it's slow in the carotids. Da-da-da-dum. Calcified aortic valve blocks the carotid upstroke. As they say, BFD. Okay, and here it is. It blocks it. Blood's unable to flow up because it's stenotic. Pretty picture. So it's blocked, it's blocked, it's blocked, it's blocked. This gets slower and later and slower and later. That's it. That part is blocked. That's what's blocked. That's what's blocked. And it's a sign also of valve gradient. This is the pressure inside the left ventricle. This is the pressure in the aorta. That valve gradient is a sign of the severity of aortic stenosis. It's the sign of it being blocked. That's the block. It's suppressed because this is the pressure in the ventricle, but this is all that makes it to the aorta. This is the pressure in the ventricle, but this is the pressure in the aorta. It's blocked. This is a different representation of the same thing. The gradient. Ooh, this is a beautiful picture. Aortic stenosis, crescendo, decrescendo. Remember, isovolumetric contraction, isovolumetric relaxation. Ooh, there's a really good one. I like this one. Let's take a look. Fingernails. Bum 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 bum. It is whose pulse? It is Quinky Pulse! The Quinky Pulse. Don't you wish you were Quinky? I have a pulse named after me. It's like, okay, so Quinky's pulse is a sign of aortic regurgitation, aortic insufficiency. When you see it in the question, your answer is say, get an echocardiogram to look for aortic regurgitation, and this person automatically needs that valve tightened up, repaired and replaced, repaired and replaced. Echo first, transthoracic first, transesophageal best. Beautiful picture of Quinky pulse for aortic regurgitation, aortic insufficiency. It's a pulsation in the nail beds, and when it's present, it just means that it's a high bounding pulse. In the carotids, it'd be called the water hammer pulse. In your head, it'd be called Demusset sign, head bobbing, and I got regurg now, da-da. In the fingernails. So when a Quinky pulse is described in the fingernail beds, you should be getting an echocardiogram and evaluating for surgical repair or surgical replacement. Super. Next sound. Stop. What's that sound? So what is it? What is it? A man comes to the erectile dysfunction. Sorry, emergency department. Comes to the emergency department with shortness of breath, jugular venous distension, edema, Ralls, and he's got suddenly worse overnight while sleeping. Okay, and he sits up and he feels better. That's called orthopnea, when you sit up and you feel better. And this additional sound is heard. And what is the sound that you're most likely, and what causes it? The most common cause of that sound. This is the cardiology section, so always say echocardiogram, echocath. The S3 gallop. Well, we did that before, yes, but it's different based on the case. The S3 gallop is the additional sound of rapid ventricular filling. The mitral valve opens. The blood rushes into the ventricle, and it hits with a splash. There's shortness of breath because you're overloaded. Orthopnea, because when you lie flat, your lungs get filled with fluid. And paroxysmal nocturnal dyspnea is because at night, again, you're lying around asleep and you wake up feeling like you're gasping for air. The S3 gallop is rapid ventricular filling, sign of congestive heart failure. In a symptomatic person, S3 gallop always means that you need immediate therapy with a diuretic. It's very serious. No one is allowed to go home and walk around with an S3 gallop. It is very serious, very dangerous, and it's always going to be hospitalized when it's associated with congestive failure, because no one should be allowed to have that large amount of fluid overload, because the S3 gallop is filled with rapid ventricular filling from massive fluid overload. The one in the healthy young person, it will never be confused, because those people are asymptomatic. The healthy young person will not be short of breath. Now, the most accurate test, not of valve disease, but of ejection fraction, is the nuclear ventriculogram. The most accurate test of ejection fraction. Now, we'll be having, you can see those things by going by test when we see the diagnostic test flashcard series. Here we're doing physical findings. The next one will be the diagnostic test one, and there'll be a most likely diagnosis one and pharmacology, because these are the four basic questions in our tests. What's the most likely diagnosis? What is the best initial test, the most accurate test? Which physical finding is most likely to be found in this patient? And what's the therapy? This test, the MUGA or nuclear ventriculogram, is the most accurate method of assessing ejection fraction. Even more accurate than an echo. Now, what do? Echo. What is the most accurate, even more than echo, for ejection fraction? The answer is the MUGA scan or nuclear ventriculogram. Look it up. Write it down and look it up. All right? Yeah, man, look it up. Takes a long time to get to be me. See you in the next section. Welcome to the final section of the cardiovascular section. We're almost done. Cardiovascular is heavily laden with heart sounds, of course, and the physiology of those heart sounds. And here we go. A man comes to the office for a follow-up of some long-standing hypertension. And he's asymptomatic, and he's got some hypertensive medications. He's got an extra heart sound. What is it? Well, this extra heart sound is from long-standing hypertension that is caused by, well, you don't have to give extra therapy because you need to treat the hypertension anyway. It's an S4 gallop. An S4 gallop does not need extra medication because you already need to treat the hypertension. So all you're going to do is just say, duly noted, S4, left ventricular hypertrophy, S4, hypertrophic cardiomyopathy, S4, long-standing hypertension, hypertrophic cardiomyopathy, no big deal. It's the sound of atrial systole going into a stiff, non-compliant ventricle. S4 gallops are associated with left ventricular hypertrophy. This is a long slide, isn't it? Oh my goodness. Now the most common cause is hypertension, left ventricular hypertrophy, atrial systole, into a stiff, non-compliant ventricle. Normally the left ventricle goes in and it relaxes. The left ventricle just sort of relaxes and floppy, But because the left ventricle is unable to relax, bang, and it hits with a slam into the ventricle. S4 gallop is atrial systole into a stiff, non-compliant ventricle and hits with a bang. So that's S4 gallop. Now there's no additional therapy because of the S4 gallop, and hypertension has to be treated anyway. So therefore you just have to know, what does it mean? It's a much more important thing for boards than in life, because we're focused in real life on what changes therapy. That doesn't change therapy. So we cool, leave it alone. A soft S1. What's caused a soft S1? It's the diagnosis when there's a soft S1. And the soft S1 is described in a question. What are you going to think about? You could be thinking about mitral regurg, because you have a pansystolic, holosystolic, tricuspid regurg, pansystolic or holosystolic, myocarditis, which infects the heart and just makes a soft S1. These conditions all are things that cause, they're all part of regurgitation that smooth out and smother out and obscure the S1. That's all you're going to get. It's going to just clog it off. No big deal. Leave it alone. Next, what is squatting and standing? Let's be 100% clear. When we squat, we're squeezing on the leg vein. We squeeze up the blood into my heart and squeeze up, fill up the heart. Standing empties the heart. The effect is to increase venous return, decrease venous return. Increase venous return, decrease venous return. And anything that increases venous return to the heart will make all left-sided lesions louder, except for hypertrophic obstructive cardiomyopathy and mitral valve prolapse. Because squatting increases the venous return as you compress those capacitance vessels of the legs and pour blood into the heart. And therefore, now the reason we're bringing this up again is sometimes people get mixed up by being told in medical school about the tetralogy of flow. The tetralogy of flow, and they go, oh, look at that little boy. He squats and he runs, and he squats and he runs, and he squats and he runs. And that's because of people thinking about increased loads and increased pressures elsewhere. That's not the main effect of squatting in the healthy normal adult or the general adult or the person who just has valvular lesions. The effect of squatting in those leg veins is to increase venous return to the heart, squeezing blood up from the legs into the heart. Now, standing opens the capacitance vessels of the legs and does the opposite, so it decreases venous return, and all lesions become softer except HOCM and mitral valve prolapse, with standing softer, less return, less blood, less murmur. Now, all murmurs increase with increased flow and return except HOCM and mitral valve prolapse. Now, squatting or leg raising are essentially equal. They're the same thing. Saying, how do I increase venous return to the heart? Well, they're both about the same. Now, our next slide, a thrill. What is a thrill? Interesting name, right? Thrill is a palpable murmur. When you see a thrill, it means evil, bad, really severe murmur. Okay? It's an extra fluid wave. This is cardiology. So the most accurate test is the echo. Transthoracic burst and transesophageal better. Catheterization technically is single most accurate, but not necessary, 99%. We want it to be repetitive so that you get it stuck in your brain like a fecalith in your circle of Willis. There's a fluid wave, yeah, ha ha! And it's such a wave, it's causing a thrill. And here, the thrill is a palpable murmur. It's a vibration from that turbulent flow. Reynolds number, remember high Reynolds number? Because this is both increased volume and increased velocity. And remember, a thrill is always pathological, because a thrill always means severe, severe murmur. And it's felt by very lightly touching. You feel it? Lightly touching, you feel the vibration. You will probably never feel a murmur with a thrill in your life, because those murmurs get replaced, those valves get replaced right away. Because if you've got a murmur that's so severe, that's level 4 out of 6, a 4 out of 6, 1 out of 6 only with maneuvers. 2 and 3 over 6, a little subjective. 4 over 6, you got a thrill. 5 over 6, you can hear it with the stethoscope off the chest. 6 over 6, you don't even need a stethoscope. Most of you here will never hear a 6 out of 6 murmur once in your life, and the murmur grading is incredibly subjective, because there's no objective demarcations between a 2 out of 6 and a 3 over 6. Mostly it's like this. 5 out of 6 and 6 out of 6 can be heard by people's relatives. 4 over 6 can be heard by the medical student. 3 over 6 can be heard by an intern. 2 over 6 can be heard by a resident. And 1 over 6 murmurs, graded murmurs, can be heard by the attending. So Reynolds number means that you've got such high velocity, high diameter, as to hear the turbulence, the turbulent flow, the turbulent flow, the turbulent flow, the turbulent flow through that heart. The thrill means that you have a very severe murmur, so severe that you've got to replace the valve or sew it shut. Any murmur that is sufficiently intense that is associated by a thrill must get fixed right away surgically. The most accurate test is echocardiography. Here's another measure of that Reynolds number. A unitless number, our friend, the Reynolds number, and that's the unit. Above 2,000 means severe turbulence. Below 2,000 is minor turbulence. The Valsalva. The Valsalva is exhalation. It's alphabetical. That's right. That's why it's like this. Where the V is. That's good, right? It means you're almost done. So Valsalva is exhalation against the closed glottis. The pushing that you would do when you're trying to poop. The pushing you would do when you're trying to give birth to babies. Exhalation against the closed glottis increases the pressure in the chest, and therefore it is a maneuver that decreases venous return. It is used to be able to say, do you have a murmur? Most murmurs will decrease with Valsalva, except mitral valve prolapse and HOCM. When you can see this in the question, it is auscultatory lesions, AR, MR, AS, MS. And Valsalva in the physical exam maneuver, you're exhaling against the closed glottis, and basically it assesses the difference between HOCM. Now that we're at the end of cardiology, I will tell you the single most commonly asked questions. You, O seekers of truth and knowledge, who have persisted to the end of the cardiovascular section, I will now give you the secret answer. The question is, Valsalva most useful for telling HOCM from aortic stenosis. Hypertrophic obstructive cardiomyopathy, crescendo decrescendo, aortic stenosis, crescendo decrescendo. And Valsalva most useful for distinguishing between those two murmurs. That's why. Valsalva, decreased murmur of aortic stenosis. Bear down, baby. You look at this guy's like in a permanent Valsalva, don't you think? Okay, and the Valsalva will decrease blood going into the heart, which results in a tachycardia, because since you have decreased stroke volume, you increase the rate. Decreased stroke volume, you increase the rate. Decreased stroke volume, you increase the rate. And most murmurs decrease in intensity and loudness. How do you expect blood to return? Oh yes, that's it. That's it. That's the Valsalva too. And so all murmurs decrease in intensity with this, except for this, and this is the answer, HOCM, AS, as the single most important thing that you use the Valsalva to tell the difference. What is the single most important use of these maneuvers? HOCM versus aortic stenosis. When the murmur increases, with Valsalva, it's hypertrophic obstructive cardiomyopathy, because anything that makes the heart smaller increases the obstruction. Smaller increases the obstruction. Smaller increases the obstruction. Smaller heart, increased obstruction. Bigger heart, less obstruction. Small heart, big heart. Oh yeah. Okay, my goodness, some legs were meant to be covered. It's varicose veins, and when you see varicose veins in that story, they are caused by standing in your legs without moving enough. And they are basically treated by either stripping them out or sclerosing them. The fancy thing to do these days is you put a catheter into those veins and put a sclerosing agent into them that literally dries them up and shrivels them up. Varicose veins are caused by incompetent valves, leaky valves in the saphenous veins. So they dilate. Those leaky valves in the saphenous veins dilate. And patients, it's not just cosmetic. These people, their legs hurt, man. Their legs hurt. Their legs hurt. They hurt because they're swollen, because they're dilated, and they have a dull ache in the legs worsened by prolonged standing, and they get better with elevation because you drain out the leg veins. And remember, severe disease gets associated with ulcers and bleeding and infection because you can actually break down the skin. It can get so bad as to actually break down the skin of your leg veins. So the varicose veins here, ultimately, it's a dilation. The blood, and remember what we said about the law of Laplace? The more it dilates, the more it's going to dilate. Law of Laplace. The more it dilates, the wider it gets, because it actually increases the wall tension. Oh yeah, as it dilates up. So the discomfort, you elevate the legs drain out, or you sclerose them out, or you compress them with venous compression stockings. And surgical removal is very difficult, but I would do it. Man, I'd do it in 2 seconds, and I don't even show my legs. I rarely wear skirts. I have a lot of hair in my legs, so you can't even see too much. But the small ones are injected with a sclerosing agent to dry them up and shrivel them. And when you inject them up here, oh my goodness, you inject them, they shrivel, goes away, you feel good about yourself. Keep your legs in the air. There you go. What is this? Yeah, I know it's an ankle. Do you know what that discoloration is? That discoloration is blood pigment in your skin. That's what this discoloration is. This discoloration is blood pigment in your skin, hemoglobin in your skin. It's like tattooing. These are venous stasis ulcers, and this is chronic venous insufficiency. And there's chronic venous insufficiency. This chronic venous insufficiency results in extravasation. Results in extravasation of blood and the hemoglobin pigment staining the skin. And the venous stasis is occurring in the elderly with chronic venous insufficiency, and the hemoglobin stains the skin, and you really can't do anything about it except to correct the underlying cause. And you can't do that so well except to say, exercise, move your legs. I stand up most of the day. How come, actually, except for the fact that they're very hairy, I happen to have beautiful legs. I do. I mean, except for my big knees. I mean, actually I don't. But the thing is, they may not be beautiful, but I don't have any veins visible. How come I don't have any veins visible? Well, besides the hair. And the answer is because I'm moving all the time. That's why. I'm moving all the time. You see, this hyperpigmentation is because the blood leaks out, and then you really can't do much of anything about it. It's oxidized heme. It cooks it. Venous stasis ulcers, very straightforward. And very straightforward means lose weight and move. 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 I like to move it, move it. You like to move it, move it. We like to move it. Diabetic ulcers break down and they can go into the bone. Those venous stasis ulcers are a disease of the elderly, a condition of the elderly, and a condition of obesity and diabetes. The treatment, here's a long line, but it basically says elevate your legs, move, correct the infection, use compression stockings, and correct the underlying cause. Ultimately, if nothing else works with it, you have to bypass the arteries to increase the supply to the legs. That's it. All right, almost down to Dwyer for cardiovascular. And a heave or a lift. The heave and the lift is you put your hand on people's chests to actually feel the movement of the heart in the thorax. Wow, people do that? Yeah. You can actually feel it. And when you see and feel the hand pushed by the chest, it's a sign of a ventricular hypertrophy, cardiomegaly. When a heave or a lift is in the question, you should be thinking of cardiac hypertrophy, a big, big heart. Here's a colorized x-ray. Very beautiful, don't you think? And the heave or the lift, the hand gets pushed up because the ventricular hypertrophy moves it out of the way and increases from diastolic filling or simply just a big heart. When you see a heave described in it, it means ventricular hypertrophy. It can be left ventricular hypertrophy. It can be right ventricular hypertrophy. But left ventricular hypertrophy is to the side and the back. Right ventricular hypertrophy is in front. The right ventricle. Now, 75% of the anterior surface of the heart, most of the anterior surface of the heart is right ventricle. Most of the anterior surface of the heart is the right ventricle. Most of the anterior surface of the heart is the right ventricle. And that gives a heave forward. And left ventricle is, as the name would say, on the left. A heave ventricular hypertrophy. Oh, a water hammer pulse. As if anybody even knew. What is a water hammer? What's a water hammer? Well, to be precise, a water hammer is a leftover from pre-steam engine times. How did you do industrial building when you didn't have electricity and you didn't have a steam engine? Steam engine, though, is, 1820s, 1830s, 30s, 40s. But the thing is that the water hammer would be that the water would lift up the hammer and then it would bang, lift up the hammer, bang. So a water hammer pulse is a water hammer would go bounding up, bang, bounding up, bang. And that's what a water hammer pulse is. When you see this, it's a high bounding pulse. It implies a very big pulse pressure. The big pulse pressure, the diagnosis associated with it is regurgitation. And this is the cardiac section for pulses, so it's actually not an angiogram. It's looking at the heart with an echocardiogram. Even though the high bounding pulse is in the carotid, what we're going to look at is the ventricle, because the large stroke volume, boom, expecting it to regurgitate back, down. High stroke volume, boom, expecting it to regurgitate down. And that's the water hammer pulse, followed by a rapid runoff. There we go. The difference between a normal pulse and the high bounding pulse of the water hammer or Corrigan's or collapsing pulse. And it is a sign of aortic regurgitation. Splash! Up, down. Oh, look at all the big filling, excess filling, excess filling. Remember mitral stenosis only went up to there? Excess filling, splash! Because it's going to be wasted. It's going to go backwards. It's going to go backwards. use a big up pulse, because it falls back down, doesn't it? So water-hammer pulse is aortic regurgitation. Now, hyperthyroidism in various hyperdynamic states where you're going to have a lot of loss, a lot of waste. It's like a military budget. Squared out a whole lot extra, knowing that about half of it's going to be wasted. The most accurate test is echocardiogram for this very high bounding pulse from big stroke volume. Remember, in aortic regurg, you're expecting to have an excessively increased ejection fraction, knowing most of it's gonna be wasted. Now, the wide split, we are down the end. Wide split and paradoxical S2. No human being can hear this. I can't. I try. Maybe I can hit a wide split. I'm trying. What's it mean? Wide split, paradoxical split. And when you hear that split, what's it mean in the history? What causes it? Well, the S2 has A2, B2, A2, B2, aortic, pulmonic, wide split, aortic, pulmonic, wide split, aortic, pulmonic. So it's split, and the aortic normally should go first. Why the aortic first? Why the aortic first? The aortic goes first because of pressure. The aortic is first because of pressure, extra pressure. Because what pushes valves closed? Pressure. Which one has a higher pressure? Aortic. So the S2 has a slight variation, 1/10 of a second, where the A2 precedes the P2. Very close, because there's a little difference in pressure, which is exaggerated by wide splitting. With what increases the pressure, delays the emptying there? Pulmonic stenosis, pulmonary hypertension, paradoxical split. Paradoxical splitting of this is the exact opposite. Wide splitting, pulmonic stenosis, pulmonary hypertension, right bundle branch block delays the P2. What delays the A2? Well, if pulmonary hypertension, pulmonic stenosis, right bundle branch block delay the P2, it must mean that hypertension, aortic stenosis, left bundle branch block delay the A2. Let's look at the split. Wide split delays the P2. Pulmonic stenosis delays the emptying, delays the closing. Pulmonary hypertension delays the emptying of the right side of the heart, delays the closing of the right heart. Delayed emptying, delayed closing. Delayed emptying, delayed closing. Ooh, that's a beautiful slide of pressures. I want you to pause on that and absorb that, because it's going to help you to understand why the right side of the heart. See, what I want you to get out of that slide is simply understanding that the right side of the heart should fill more when you inhale. The right side of the heart fills more when you inhale, and the left side of the heart fills more when you exhale. So let's do that again. Oh yes, beautiful. I love it. That's such a beautiful picture. I can't stand it. It's so pretty. Wide split is caused by delayed emptying the right side, because it's delayed electrical stimulation. Pulmonic stenosis, delayed emptying, delayed closing. Pulmonary hypertension, delayed emptying, delayed closing. Paradoxical split, the other way around. What delays the aortic emptying? Left bundle branch block. What delays the aorta emptying? The left ventricle emptying. Aortic stenosis. What delays it? Hypertension and hypertrophic cardiomyopathy. Look them up. It's not going to change. Physical findings don't change. That's why we're doing these with lots of images. And if we tried doing it with this number of images in a slide deck, in a physical flashcard, you'd have to make 750 cards. Here you can just say, I've seen everything, and you're done. Yes, you are. See you soon.